because last day, so we shall be sticking to times a bit more tight today. So be very crisp and what do you call short whenever you are presenting. Okay, because we have to close up with the award ceremony and other things also today. So that is important to understand. Mangaraj. So the first participants, Dr. Kaushal and Dr. Niyogi. You can just pick up one amongst it. No. So Dr. Kaushal will speak for, correct? Topic, you just introduce yourself, topic, and then start. We require the timer to be on. It's ready. It is not 10 actually, it is 8. Yeah. So 8 minutes, correct?
Yes. So, good morning, respected judges and dear colleagues. Today, my topic is why radioiodine ablation is the best treatment for the Graves' disease. And I'll be speaking for it. So, what is the best treatment for any disease? The treatment should be affordable, acceptable, applicable to large group of the patient, and it should be safe. And radioiodine ablation almost fulfills all the criteria for it. It is there with us for more than 7 decades. It started in 1940. So now we have enough data regarding its safety and efficacy. Also, it is a single-day OPD procedure. So in the young patient, we can give one just single tablet and they are permanently cured. So imagine a disease which can be cured with a single tablet and the patient is cured for the life. Also, it is cost-effective because there is no recurring cost because with ATD, we have to take for a longer duration. And we also need some investigation for its safety and efficacy ongoing. So this recurring cost is not there with radioiodine ablation. And obviously it is more cost effective than the surgery. As it is only applicable on the single day OPD procedure. So obviously it is acceptable to the large group of the patient. With only minor safety precautions are required, which can be easily handled. Regarding the safety aspect, So initially there were concerns regarding the increased mortality and increased cancer risk. But ultimately it was found that increased mortality was due to actually uncontrolled hyperthyroidism and not the radioiodine ablation per se. Also regarding the cancer risk, the only one study has shown that increase in the risk of non-thyroid malignancy, solid organ cancer risk, that is CA stomach and CA breast, but they use a very high dose of ablation. And ultimately ATI denies any risk. Another concern came regarding the cancer risk due to incidents of Hiroshima and Chernobyl incidents, where children had high risk of the thyroid malignancy detected. So they thought that if we give radioiodine ablation also, it will mimic the same thing. But in Chernobyl and Hiroshima, it was external low dose radiation. While what we are giving here is an internal comparatively high dose radiation. And in children, we target for hypothyroidism, not the euthyroidism. So when the thyroid tissue is whole burnt, actually there is a decreased risk of malignancy, not the increased risk. The another advantage with radioiodine ablation is very rapid control compared to ATD. Also, as we know, ATD has many rare but serious side effects like pancytopenia, hepatitis, vasculitis. It is rare, but once it happens, it affects the morbidity significantly. It increases the cost of the treatment, and also it affects the quality of life, and sometimes it can be fatal also, like fulminant hepatitis, which are not the concern with the radioiodine ablation. And if patient is on ATD and this side effect happens, and if we have to stop the drug anyway, and in such a morbid condition, patient can't undergo surgery, then we are left only with the one option, that is radioiodine ablation. Efficacy, almost 90% of the patients are cured with a single dose of radioiodine ablation. So that good efficacy we can get with the ablation. And if a patient has a chronic liver disease or a very elderly patient with atrial fibrillation and heart failure or pulmonary hypertension, radioiodine ablation is a first-line treatment preferred, even by the guidelines. On the other hand, if we go for opt for the surgery, there is a risk of anesthesia, recurrent laryngeal nerve injury, or a risk of hypoparathyroidism, which will affect the quality of life as well increase the cost. So these are not the issues with the radioiodine ablation. And also it is quite difficult to find a high volume surgeon in India. So all in all, it is affordable, efficacious treatment, acceptable and applicable to the large number of the patient. So I think it is the best treatment for the Graves' disease. That's all for us.
Start. So shall I begin? Okay. Very good morning to respected judges and to all my fellow colleagues. And I am going to speak against the motion. And first of all, I like to congratulate Kaushal for bringing up the points so well. And he's a very good friend of mine, but I beg to differ with him in this aspect. And why I am giving the points. For being the best modality, the best treatment modality, the most important thing is availability. We are not living in USA or we are not living in Europe. And I'm not going to discuss, but in a third world nation like India, the availability of radioiodine therapy is a concern. In the metropolitan cities like Kolkata, Delhi, Hyderabad, it's readily available. But in a scenario in Bengal, if we move 30 to 40 kilometers away from Kolkata, the availability is an issue. And in the remotest and the remotest of the place, the anti-thyroid drugs will be available. The surgery, we can go for surgery. However, radioiodine therapy, the availability will be issue. The second point is acceptability. I don't know, after the patients which come, the Graves' disease patients which come to our OPD, after explaining all the pros of radioiodine therapy and explaining that it will be a one-time treatment on everything, but there is an intrinsic inertia to initiate radioiodine therapy, and this cannot be overcome, what I have felt at a personal level in the OPD. The second thing is that for becoming the best treatment, there should be a generability, means it should have been generalized. But radioiodine therapy, first of all, in the pediatric patients, in less than 5 years of age, it is contraindicated due to the increased risk of malignancy. Coming to the 5 to 10 years age, it has been recommended by the ATA that doses less than 10 millicurie have to be given. That the problem is that there is a gray zone, as because if we give lower doses and if there is remnant thyroid tissue present, that will lead to increased risk of malignancy with radioiodine therapy. And after that, we are comparing radioiodine therapy with the other existing modalities like anti-thyroid drugs and surgery. And what we have seen also in cases of thyroid eye disease, where thyroid eye disease is present, then the giving radioiodine therapy will increase the TRAb levels and will exacerbate thyroid eye disease. And also, there is certain risk of radiation associated thyroiditis, radiation injury, like persistent pain in the neck can be present, or there can be salinitis, which can be an important concern for the patient. And regarding the other treatment modalities, like the side effects of anti-thyroid drugs, that it has been said that radiotherapy is a one-time treatment, and after that, compared to anti-thyroid drugs, what we have to give for a long time, and the side effects will be more. But I think that the side effects of anti-thyroid drugs are more prominent in the first 6 months, and after that, and it also it's idiosyncratic, but it has it occurs at a higher dose. So once the disease process is controlled, and after that we are giving anti-thyroid drugs at a lower dose, after 6 months, the side effects will is quite rare. And apart from that, for in cases of milder Graves' disease, where the chances of remission are high, like female patient with small goiter, the thyroid hormone levels are not high. In that cases, the anti-thyroid drugs may be preferred, as because the patient have increased chances of going to remission, and they don't have to receive long-time levothyroxine therapy. And another important concern with Graves' disease is that the radioiodine therapy with Graves' disease is that increased risk of malignancy. It has been said that although there was in a study by Russell et al., it was shown that there is no increase, there is no statistical significance increased risk of second cancers, but there was an increased trend towards certain cancers. Like there was increased trend toward breast cancer, it was increased trend toward colon cancer. So there is a chance, and this means this area remains in a gray zone. Also, there is with radioiodine therapy, there is patient-related concern, like the patient have to follow radiation safety for some duration of time. And apart from radiation safety, also apart from radiation safety for the patients, for the female patients who wish to become pregnant, they have to wait for at least 6 months, and preferably 1 year after receiving radioiodine therapy. And not only that, once they have received the radioiodine therapy, and after that there is also chances of transplacental passage of TRAb, which can lead to fetal thyrotoxicosis in the newborns. And also with this, it has been argued that radioiodine therapy is a single modality treatment, but the problem is that it's not efficacious in a single dose, and we require second or third dose of radioiodine therapy. And once we are counseling the patient at the first, that we are saying with that once you get this radioiodine therapy done, then after that there will be you don't have to do anything. And once the patient doesn't go to remission, then it remains a problem. And also in cases of large goiter, you do not have any option, because their radioiodine therapy will probably not be efficacious, and you have to go for surgery. And people have taken points again that surgery has this problem, there is risk of serious hypoparathyroidism. But the point to be remembered is that hypoparathyroidism is a very rare complication. It occurs less than 5%, and in high volume surgery, it occurs less than 1%. So we should not think of something which is very, very rare as a complication. So another thing is that the efficacy of radiotherapy like it is preferred in America, USA, but in Japan it is not preferred. One of is that the increased risk of malignancy, that with the Hiroshima and Nagasaki incident. The second is that they consume high amount of seafood which are rich in iodine, and those places where the iodine consumption is increased, there the trapping of radiotherapy will be affected, and the efficacy will be hampered in this. So I want to summarize by saying that there is nothing called best treatment modality, and there should be a patient-directed approach. And according to the patient characteristics, and according to the treatment available, and according to the acceptability of the patient, we have to decide what treatment we are going to give. With this, I want to end. Subhash.
2-minute timer.
You said first I will speak.
Can you reset the timer?
Yeah, it's already. Yeah.
Your time starts.
So my friend told about the inertia. So I think that inertia is more from the doctor side rather than the patient side. If we are not explaining well to the patient because of certain restrictions, the patients are not accepting the treatment. Another thing he told about the cancer risk in children. So even with the ATD, the risk of remission in children is only 20 to 30%. So if after 10 years, if we can give radioiodine ablation, it is better for them because most of them going to require the ATD for the longer time. And 90% patients are requiring the single dose, not the multiple dose. So that is quite efficacious treatment, I will call. Also, the Graves' orbitopathy prevalence in India is around 30% of the Graves' disease patient, and 85% of them are mild and inactive. So in such patients, radioiodine ablation will not exacerbate the disease much. And smoking is a major risk factor. So if we can explain the patient to convince the patient to stop the smoking, then this risk also further comes down. So that should not be a major problem in avoiding the treatment, at least in the majority of the patient. And managing the hypothyroidism with the ATD is difficult to manage and titrate the dose compared to the hypothyroidism, which occurs after the radioiodine ablation, because we can easily manage it. And there is always a persistent risk with the ATD. We say it is initially in 6 months only, but there is always persistent risk. And for that patient, it is 100%. If patient gets the pancytopenia or fulminant hepatitis, the quality of life is very bad after that. That's why ATA prefers as a first-line therapy in the patient with the Graves' disease. That's all from my side. Thank you.
Yes, I agree with some respect to Kaushal, but I don't think that inertia is more on the doctor's side. That means we are all physicians and we all want the best treatment modality. And it's not like we have not counseled the patients. We have extensively counseled the patients, and after that, there is inertia that they are not sure about. We have explained everything, but they always prefer of taking drugs than any other modality of treatment. The second is regarding the cancer risk, what he has told about that the cancer risk has been not with increasing dose. However, the studies which have been done, there was, as I have already said, that there is an increasing trend towards the cancer risk of certain non-thyroid cancer and thyroid cancers also. And if you consider that it has been said that the cancer is not statistical, but statistics are not always true, and they always reflect what they want to show us. So there is a concern, and as seen in the Japan and in the Chernobyl, and after that the radioiodine therapy, there is increased risk of cancer. So we should be cautious, and we should avoid radioiodine therapy in children. And third is that low dose carbimazole therapy is quite effective, and in low dose carbimazole now it has been recommended also that patients who do not go into remission, you continue with low dose carbimazole therapy. That's not an issue, as because the side effects are quite. So I want to say that the topic here given is the best modality, but I don't think there is anything called best, and it all depends on patient-centric approach. Thank you.
What does the word theranostic mean to you? Theranostic. What does it mean? Either of you.
No, sir.
Which is the first theranostic modality identified in the world? You can ask a friend.
Sir, theranostic is something which has dose therapeutic effect and diagnostic effect. like radiation therapy. It has in radiation scan also in therapeutic effect.
Well done. So the aim of getting you to debate is because when you go out into practice, you will find that this will become a major part of your career. It's not debating necessarily, but speaking at different platforms, at different fora, in vernacular language, in English, for public awareness, for academics. So the aim is actually to make you comfortable with this. So were you happy when you were debating?
Yes, sir. It was a good experience at this platform.
So how will your body language reflect that you are happy? Which round? Just
So smiling.
smiling. Yeah, so do that. Well done.
Thanks.
Can we have the next set of debaters? What have you picked up? It's a no. So your opponent goes first. You introduce yourself and talk. Start. Yes. You're the first.
My name is Dr. Harshita. Good morning, respected judges and my dear colleagues. The topic for debate that is given to me is thyroid peroxidase antibody is useless in endocrinology, and I'm speaking for it. So since I'm going first, yes, sir. Since I'm going first, I'll just briefly say what is the context of thyroid peroxidase antibody or TPO. TPO is it is an enzyme that is earlier called as a microsomal antigen that plays an important role in the early steps of thyroid hormone synthesis in oxidation and organification. And the antibodies that develop against them is the topic for today's debate, that is TPO antibodies. So I would like to organize my talk into the following headings. The first will be regarding the pathogenesis of TPO. Then in the context of overt subclinical hypothyroidism, pregnancy, and other special situations in endocrinology. So coming to the pathogenesis part first, it is very well known that autoimmune thyroid diseases are predominantly T-cell mediated disorders. And if at all any contribution by TPO antibodies is considered to be very minor when compared to T-cell mediated as well as cytokine mediated immunity. And that probably could be one of the reasons why disease-specific therapy against TPO might not play a much significant role against autoimmune thyroid diseases. Moving on to its role in overt hypothyroidism, I think it is redundant to check for TPO antibodies in the context of overt hypothyroidism when almost, especially in iodine sufficient settings, when autoimmune thyroid disease is the predominant cause of overt hypothyroidism. And also it is well known that 10% of the normal population can still have TPO antibodies but are not hypothyroid. Also, patients with Hashimoto's disease up to 10% can be antibody negative. And this TPO antibody status will also not determine the severity, meaning if a patient has higher titers, it doesn't mean they have more severe hypothyroidism, or it also does not help us in setting the dose of levothyroxine for the patient. And currently, as I already said, there are no specific treatment targets in overt hypothyroidism for for TPO, and I don't see any utility in checking for the same in patients with overt hypothyroidism. Coming to subclinical hypothyroidism, that is the place where TPO is thought to be having a major role. I think the progression from subclinical to overt hypothyroidism is a very slow process with an annual rate of around 2 to 5%. So the utility of checking it and the cost constraints or the cost effectiveness has not been widely studied. There are few studies in pregnancy, I do agree, but in general population, it is not well studied. Also in pregnancy, those high risk situations where subclinical hypothyroidism is actually more important and needs to be treated, they're already being treated, and I don't see the extra role that TPO testing can offer there in such settings. And Coming to euthyroid individuals and checking for TPO antibodies, the rate of progression in subclinical hypothyroidism itself is 2 to 5%, and I think it is not justified to check euthyroid individuals, though people with higher TSH levels and anti-TPO status are known to be at higher risk of overt hypothyroidism. Coming to pregnancy, which is a very risky topic to say that TPO antibody testing is not advised. There are few studies to say that TPO antibody status in pregnancy is interdependent upon maternal iodine levels, which shares a U-shaped relationship. So it is in turn all dependent upon the iodine levels of the mother, and it does not directly reflect her antibody status. Also, anti-TPO has touted to be associated with spontaneous pregnancy loss, but in those studies, majority of the women were older, and also their TSH levels were slightly higher, leading to recruitment bias. And also in recurrent pregnancy loss, the data with anti-TPO is not robust, and for preterm deliveries also, it is not robust. So there were many confounders in these studies to suggest that anti-TPO is directly associated with either spontaneous or recurrent pregnancy loss or in preterm deliveries. Anyways, when you are treating the mother with levothyroxine, I don't see any rationale for again doing it. There is a recent trial called Tablet that was published in NEJM in 2019, which states that supplementation with levothyroxine does not offer any additional benefit in preventing preterm deliveries or spontaneous pregnancy loss. So it is necessarily like whether the mother is TPO, TPO positive mothers do not derive any benefit from being treated with levothyroxine. And coming to infertility, it has been shown that ART outcomes are similar in both TPO positive as well as negative groups recently, and I feel that the utility is lesser there also. And though ATA guidelines recommend giving levothyroxine, it is only a weak recommendation based on low quality of evidence. And coming to fetal passage of anti-TPO and its risk to the fetus, as there is no proven role of thyroid dysfunction in the fetus, I don't think that justifies us in testing TPO antibody status. And coming to Graves' disease, almost 80% of people with Graves do have anti-TPO positivity. It does not tell us anything about the severity of Graves like TRAPS, or it does not tell us about the relapse potential. Also, once you stop antithyroid drugs, the TPO antibodies generally rise. So it is not linked to the etiopathogenesis of the disease, and hence does not offer any role there. Coming to special situations in endocrinology where thyroid autoimmunity needs to be tested, I do agree that TPO might play a role there, but then as in like type 1 diabetes or Turner syndrome or Down syndrome, celiac disease, and all such special situations. But I think since they are people at high risk, we can as well monitor them with TSH per se, rather than spending extra on anti-TPO in resource poor settings. So I would like to summarize that though the word useless is a very strong word to describe an biochemical investigation in the context of any disease, I feel that any investigation should be justified before we order for it, as in it should either offer to the diagnostic role, it should have a strong diagnostic role, or it should have a role in therapeutic decision making, which unfortunately TPO does not change, or it should have a role in identifying the like prognosis of the disease or the disease course, which again levothyroxine alone has a benefit, and anti-TPO does not alter our treatment course in these patients. So I would like to sum up saying that anti-TPO might not in terms of diagnosis or therapeutic decision making, it does not change much. We can simply rely on TSH as it is more cost effective, especially in resource poor settings. And also anti-TPO is dependent upon the assay that is used. And some studies that have come out recently have shown that this anti-TPO assays, they are standardized based on young men who are less than 30 years, who don't have goiters, whose TSH is between 0.5 to 2. Which is actually not the ideal scenario and can't be applicable in all situations, especially pregnancy, very elderly, and in children. So with this, I conclude saying that anti-TPO might not be a good choice. Thank you.
Good morning, respected faculty and my dear friends. So I'm Dr. Lavanya Boni. I'm here to speak against the motion thyroid anti-TPO testing is useless in thyroid disorders. So thank you, Dr. Harshita, for your excellent delivery. But I will choose to highlight a few points here that she may have omitted in her talk. So I will start by saying that anti-TPO antibody testing is an indispensable ingredient for treatment of any thyroid disorders. First, I'll talk about the screening, usefulness in screening. So the place where thyroid antibody testing has been found most useful to be screened is in the reproductive age women, in which it has been shown time and again that anti-TPO antibody positivity can lead to an increased risk of irregular cycles, infertility, and miscarriage. And since this accounts for a large part of the population who are predisposed to thyroid disorders, I suggest we should not ignore this population. Also, in pregnancy, it has been shown that anti-TPO antibody positivity has been linked with prematurity. This is because the fetus, there is shown to be impaired responsiveness to HCG in the fetus when the mother is anti-TPO positive, and this may lead to prematurity. And in certain few studies, it has also been shown that it can also induce hypothyroidism in the fetus. Other adverse pregnancy outcomes of anti-TPO, which anti-TPO can predict, include increased risk of gestational hypertension, and it can also very important to predict the risk of postpartum thyroiditis. So in this way, while if we screen pregnancy, other than helping in treatment, it can also help to predict the women who will be predisposed to postpartum thyroiditis, in which case we can ask them to follow up frequently after delivery and detect these cases before they go into frank overt hypothyroidism. And as a screening test, it's 88 to 90% sensitive for detecting Hashimoto's thyroiditis and slightly lesser for Graves. Now, next coming to the diagnosis, anti-TPO antibody can predict the occurrence of Hashimoto's thyroiditis up to 7 years before the onset of disease. So like a study by Srivardhane et al. Showed, in hypothyroid patients, 73% of patients develop TPO antibody positivity prior to the onset of disease and around 14% in parallel, whereas in Graves' disease, up to 60% develop previous to the onset of disease and around 13% in parallel. So we can actually predict the occurrence of disease much well before in advance. Another place where it's useful is in a patient who has subclinical hyperthyroidism, in which an anti-TPO antibody positivity will point in favor towards an autoimmune etiology compared to just a simple viral thyroiditis. And we can also, another thing, we can predict the progression of subclinical hypo to overt hypothyroidism. Though Harshita has mentioned before, I would like to emphasize that a person who has anti-TPO antibody positivity will have double the rate of progression to overt hypothyroidism compared to someone who's anti-TPO negative. So up to 4.3 to 5% per year compared to a person who's 2.6% for a person who is negative. Next, coming to decision to treat. Regulatory bodies like the American Thyroid Association, AACE, and the Royal College of Physicians all advocate treatment for an anti-TPO antibody patient. So I think we should not ignore such guidelines. And it has also been shown that subclinical hypothyroidism, where there is an inertia to treat, we don't know whether it's significant or not, whether transient or not. An anti-TPO antibody positivity can lead to better confidence for the physician to treat the patient. We can tell them that since the anti-TPO is positive, there is less chance for the TSH to return to normal without treatment compared to a person who's negative. So it will give better confidence to the physician to counsel the patient. Another thing is from the patient side. The patient, any patient who's told that they have a thyroid dysfunction, the classical question they ask is, do we need to continue treatment lifelong? So the way the Synalco helps in counseling the patient, tell them that since your anti-TPO is positive, yes, there is a high chance that you may have to continue lifelong, that it's a lifelong process. So the patient will also be put at peace of mind regarding what their disease pathogenesis is. We can also tell them that it has a heritable component, that it may be there in a few of your family members as well. So that was about its role in hypo and hypothyroidism. Now moving on to the next category, that is malignancy. So the standard of care for any thyroid nodule is FNAC. FNAC, and if it's seen to be benign, we need some more predictors that can predict the occurrence of malignancy. In studies, it has been shown that anti-TPO positivity in an FNAC proven benign nodule can predict the risk of malignancy in that particular nodule. Example studies by Wong et al., Kratky et al. Have shown that there is an odds ratio of 2.2 to predict the risk of malignancy in an FNAC positive, FNAC negative benign nodule if the patient is anti-TPO positive. Now, moving further on with malignancy. Suppose a patient already has a malignancy, differentiated thyroid carcinoma. We are following up the patient. This can serve as a prognostic marker as well. It has been shown that differentiated thyroid carcinoma, when it moves further on and it goes into de-differentiating levels, this can lead to decreased titers of anti-TPO antibody. So it can prove as a screening modality, as a diagnostic modality, to decision to treat, to counsel the patient, to diagnose malignancy, and even to prognosticate certain malignancies. Now, since disease don't follow textbooks, I will talk a few words about few other autoimmune disorders that I'm shown to link with anti-TPO positivity. So other disorders, for example, type 1 diabetes in young, where we may be at a confusion whether the patient is autoimmune or not. Anti-TPO can help in pointing towards autoimmunity. Other disorders like Hashimoto's encephalopathy, where anti-TPO antibody is the most common factor involved. And so I would like to conclude by saying that I will repeat my sentence. It is an indispensable ingredient to treating of thyroid disorders. And though subclinical hypothyroidism does not have a very robust guidelines, we should not ignore the major part of the population. That is a very vulnerable portion of the population, that is pregnancy and reproductive age women who will develop, who will benefit from doing anti-TPO testing, because not only for them, but for their offspring as well. And it should be used in every subclinical hypothyroidism, in every subclinical hyperthyroidism, in all reproductive age women, in screening in pregnancy, and it can also to predict postpartum thyroiditis. So addition of this to traditional markers like TSH, T3 and T4 will be very useful to address the morbidity of this condition and to reduce the health concerns. Thank you.
Can I start, sir? Dr. Lavanya has brought out many valid points regarding why anti-TPO is negative in the context of thyroid diseases. I would like to disagree on the word indispensable because I don't think it is indispensable to all thyroid diseases as mentioned, because in current practice, we generally do not order anti-TPO for all the thyroid patients that walk into our OPD, and we treat them and they are happy with the treatment. And any investigation should be customized to the patient population that is approaching us. We should also keep in mind that the facility for anti-TPO might not be available in all settings, but we yet treat hypothyroidism or any other, for that matter, any other autoimmune thyroid disease. And regarding postpartum thyroiditis, which I missed mentioning, I feel that the doing anti-TPO might tell us who is at risk, but it does not help in differentiating graves or the thyrotoxic phase of the postpartum thyroiditis. And also it does not tell us anything about the disease course of who will ultimately become hypothyroid, thereby not adding much to the potential there. Also, ATA mentions that hypothyroidism in the fetus is not a complication of anti-TPO positivity in the mother. So I don't think there is any role of predicting fetal hypothyroidism from a maternal anti-TPO perspective. And regarding predicting, hypothyroidism is predicted by an anti-TPO positivity 7 years earlier. There are scoring systems for that, like TIA, wherein if a person is having a positive family history of thyroid disease and with their TSH values as well, we can do that. So I would like to conclude that, as pointed out by Dr. Lavanya, it is not a very indispensable tool. It is ultimately dependent upon the settings in which we practice and also the patients, how well we treat the patients and ultimately relieve them of their symptoms. Thank you.
Thank you for your feedback. I would like to apologize for calling it indispensable. I will change it to indispensable in a particular portion of the population, that is in young females. So in young females who are in the reproductive age group, I would still believe that anti-TPO testing is an indispensable component of care and should not be neglected. And it should be given to as many patients who have access to it. And that is all. Thank you.
Comments? Any comments?
Yes, basically, there was a point raised by you that in subclinical hyperthyroidism, validity of antithyroid antibodies. So probably you mentioned this thing. So do you still feel that it is important or some way it will help in diagnosis or management of subclinical hyperthyroidism somewhere?
At least we can, so patient who's positive, sir, we can at least follow up the patient and see whether they develop into frank. There will be more a chance to develop, go into the hypothyroid phase. So a positivity can still help
So you
follow
tend
up the
to
patient.
say that rather than diagnosis and management in terms of its conversion into hypothyroidism, is there any evidence that antibody positive patients, they tend to develop hypothyroidism in future?
Yes, sir, I believe there is.
Yeah.
Anti-TG and TS receptor antibody. A TRAB antibody will be done. It can blocking and stimulating TRAB antibodies.
So, as far as hyperthyroidism
in a resource poor setting where we can't afford TRAB, we can do anti-TPO.
Here I would like to mention one thing.
with hyperthyroid, just in the subclinical hyperthyroid space, he says that anti-TPO is useless.
No, sir. No.
So you use the term resource poor settings, and earlier speakers, they mentioned they use the term third world countries. So will you still like to label yourself in third world country? In the today's world with Russia-Ukraine war, you can say that you are in third world country?
Actually, I had apologized beforehand. The third
so probably it's the time when we should start recognizing our potentials. We should place ourselves in the appropriate platform rather than calling ourselves as blacks, as resource poor is okay. That it is different. But third world country is ridiculous. Thank you.
What are the surrogate markers? Anti-TPO is not available. Any surrogate symptoms, surrogate signs, surrogate laboratory abnormalities, which will help you replace make decision.
Family history of thyroid disease or any other autoimmune.
Only one symptom, one sign, one.
Goiter, any goiter will increase. Then any dyslipidemia, it can also help to guide treatment. Then positive family history, yes.
I'm just giving you now which side of the debate are you on? So the point is that you have surrogate values there, the symptoms, the signs, the labs that they can help you. We should care is the teamwork. So the debate is there, that is separate, but that is the beauty of technology and opinion technology working together. Third topic.
What is your no.
Good morning, respected judges, my fellow colleagues, and all members of the House. The topic for our debate today, I am topic number 3, that is insulin pumps in the management of type 1 diabetes mellitus. And I stand here, pardon? Aviva Avasti, sir. Yes, sir. And I stand here strongly supporting the motion. I would like to tell you a snippet of a case which came to our OPD a few days back, like last week. She was a 19-year-old girl, a diagnosed case of type 1 diabetes since the last 5 years. She had come to us with diminution of vision in both eyes for like 2 months. So we planned to admit her to look at diabetic complications. So we looked at her sugars. Her fasting plasma glucose was around 100 to 140, and her postprandial was between 150 to 200. She was saying she was regular on basal as well as bolus insulin. However, her HbA1c was 10%. So when we admitted her, we saw that she had severe non-proliferative diabetic retinopathy and she had AION. So we thought of giving an ophthalmology consultation for the AION. So they had advised us to give corticosteroids for the patient. However, she also complained of left flank tenderness. So we got an ultrasound done, which showed an enlarged left kidney. So we got a non-contrast CT done, which showed emphysematous pyelonephritis in this patient. During the course of the hospital stay, she also said she had difficulty in walking. She had a left-sided ankle drop. So in this snippet, I would like to tell you that this patient, who is fairly educated, is taking regularly basal bolus regimen insulin. Her plasma glucose is fairly under control. I wouldn't say it is the best control, yet she has developed such diabetic complications. Why did she develop this? In spite of taking regular basal bolus insulin. So my point here is that patients who are taking basal bolus insulin might not have adequate control. They might still develop complications, and the cost of treating such complications is much higher than the cost for maintaining adequate glucose control. Looking at history, we see how we have evolved, coming from unicellular organisms to primates to humans that we are. Looking at how technology has advanced. Not in my time, but earlier in your time, there would have been cathode ray tube televisions, and one household would have had one big TV, and people from everywhere around the village or the town would come to sit and watch TV. Now what do we have? We have smartphones where we watch our Netflix or Amazon Prime. We have OLED TVs, which are like so thin, paper thin TVs. Earlier we used, not in my time, obviously, there were big telephones where you would call the operator and tell them, please contact this person. Then we had cell phones, which were really big bricks. Now we have smartphones, with which we can video call. So we see technology has advanced. Similarly, in 1870, in France, they advocated the Bouchardart diet for control of increased glucose. Allen's diet was a similar diet introduced in America, which said, obviously, if you reduce the sugar intake, you will reduce the complications of diabetes. It was only in 1922 where Banting and Best, along with Collip, they extracted the Collip's formula, Collip's extract, and they gave it to Leonard Thomas, the 14-year-old boy who was unfortunate to be diagnosed with type 1 diabetes. His symptoms improved and he led a good life up to 35 years of age. Furthermore, I would like to strengthen the point that prior to the discovery of insulin, DKA was universally fatal. However, after the discovery, it has reduced to now 0.3% mortality. So type 1 as an epidemiological crisis in the world, earlier, the incidence of type 1 diabetes was around 70,000 in 2001. However, now in 2021, between 0 to 19 years of age, the incidence of type 1 diabetes, the prevalence is around 2.2 lakh patients. Managing type 1 diabetes is of utmost importance as evidenced by the DCCT and its continuation, that is the EDIC trial. In type 1 diabetics, there is no endogenous beta cell reserve, and conventional modes of therapy will lead to hyperglycemia, hypoglycemia, as well as increased glycemic variability. Time in range in such patients is of utmost importance, and as it has been defined, between 70 to 180 milligram per deciliter for at least 70% of the day. Therefore, it is necessary that we explore other ways of administering insulin. And in 1964, the first insulin pump was developed in Los Angeles and it was used. Again, as I claimed about technology being big, becoming miniaturized and more accessible to the population, the first insulin pump was the size of a backpack. But now when you look at the current insulin devices, they are so small that you can carry it around with you. So that is the first point. My worthy opponent might say that there are limitations and shortcomings to insulin pump. For example, the cost involved, or there might be technical failure, but I would like to say that with adequate information, adequate counseling to such patients and subjects who are having diabetes, these complications can be reduced. We have many insulin pumps available in India, the cheapest one starting for around 1 lakh rupees, and it can go up to 3.5 lakh rupees. As the president of ESI, Professor Sahai, had once published an editorial in the IJEM. He talked about diabeto-economics. Now, I agree that insulin pump might be slightly expensive, but it is not as expensive when we face a complication which might lead to a financial catastrophe in these patients. A patient with a diabetic ulcer, which is complicated, will have to pay much more, with much more morbidity than a patient who is just taking MSI. These patients will pay much more and they will become financially bankrupt. Furthermore, insulin pumps are painless. They have a plastic catheter, they has a tubing, and it has a pump with a double Duracell battery intake. Some delivery systems also have a continuous CGM monitor attached with it. Furthermore, there are new types of insulin pumps, especially in the closed loop pumps, where they have dual hormone release with either insulin or with pramlintide or glucagon. This is especially required for patients who have brittle diabetes who cannot be controlled properly. In this era of patient-centered care, we would strictly want to tell the patients that treatment of diabetes is not as hard as it was earlier. A patient does not need to be pricked at least 4 times for insulin and at least 4 to 7 times for glucose monitoring. Furthermore, I would like to say that these pumps rarely fail and they have been seen in various head-to-head trials. For example, the STAR-3 trial, which had showed that there is a reduction in HbA1c of around 0.3 to 0.4%. There's a reduction in nocturnal hypoglycemia and there's a reduction of the total insulin which is required. Furthermore, however, this was not a RCT. It has been seen in GDM. There is reduced dose of insulin required and there is a reduced incidence of complications during delivery in patients who are receiving insulin pump therapy. Furthermore, insulin pump, we have newer pumps which stop the release of insulin when the plasma glucose is reduced also, and they might also stop the release when it is coming towards the lower threshold for hypoglycemia. So I would like to say that type 1 diabetes is an unfortunate reality in our world and we need better therapy. And currently we can still justify the use of pumps and it will only increase in the future. Thank you.
Good morning, respected judges and dear colleagues. We are debating on the topic about insulin pump being the best modality in the management of type 1 diabetes mellitus. Type 1 diabetes mellitus, as we all know, is characterized by the autoimmune destruction of the pancreatic beta cells, and it's an absolute insulin deficiency which we are dealing with. So there is once the concept of the insulin inertia, as Dr. Sanjay Kalra has always enlightened us, that the major pillar of diabetes treatment, that is insulin, the first inertia is on the part of the practitioner as well as the patient. And once we have convinced the patients with type 1 diabetes that insulin is your only modality of treatment, the modality of treatment which we later on apply for them, including multiple daily injections or an insulin pump, becomes much easier for us. But after saying this, I would say that as Dr. Avasthi said also, he has made my job a little more easier, that insulin pump has a lot of disadvantages to it. So insulin pump generally has a reservoir, a plastic tubing and a catheter which is inserted into the subcutaneous tissue. And the major advantages are the flexibility of dosing. But what are the disadvantages? It requires only a very educated, motivated and affordable consumer who can use this insulin pump. We know the starting price of insulin pump is 1.5 lakhs. But if you look at the Medtronic 670G, which is available now, which is the closed loop hybrid system, it costs around 6 lakhs. And what about the consumables associated with it? They have to also change this plastic cannula every 3 days. Otherwise, there is a risk of infection. There is a risk of allergy to the adhesives. So it is not very user friendly, though it is very good in terms of reducing the hypoglycemias as well as the DKAs in patients with with type 1 diabetes. It carries a lot of adverse effects. And secondly, I would say is that more than the patient, we should have a very good educator team. We should have a very good caregiver team who always motivates these patients to take this, come for regular follow-ups, because insulin pumps need a steep learning curve. There is a learning curve associated with it. So in the initial 1 to 2 months of starting the pump, the patient has to be on a regular follow-up with the educator and the caring team. And thirdly, I would say that it is not very useful for blind patients. We cannot prescribe them to somebody who's blind. So fourthly, in our country, many of them, once they invest on something like an insulin pump, which is very expensive, they expect it to cure their diabetes, which is not at all the point. It is not possible. If we have to convince them, we have to educate them that this is a modality of treatment which requires a continuous follow-up. And the other points which I would like to say in insulin pump is that there is, though in research settings, it has shown that there is a less chance of hypoglycemia, and DKAs are not very common with insulin pump. These are in research settings. There are many individual studies which have shown that when there is a pump malfunction, when there is a tubal block, there can be reduced delivery of the insulin, and it has led to some cases of fatal hypoglycemias as well as diabetic ketoacidosis in individual studies. But in a research setting, maybe these studies have shown lesser incidence of DKA or hypos. And then I would like to say that this plastic tubing and all these are to be worn on the physical stature of the patient. So it is quite cumbersome. And there are incidents of this tubes getting, these are all practical things, like if the tubes can get blocked, the tubes can get, while walking, it can get, it is not very user friendly. And another thing which I would like to say is during swimming, showering, these sometimes you might have to take off these pumps, and at these times what can happen is there is a chance of decay. There is no basal insulin infusion at those times. So given the advantages as well as disadvantages of insulin pump, of course a very educated, motivated and affordable consumer is the target for the insulin pump. Thank you.
Good morning again, respected judges and my fellow colleagues. As my worthy opponent just now spoke, it sounded to me that she was reinforcing my own views. She says that there is absolute insulin deficiency. I do agree there is absolute insulin deficiency. So that does lead to glycemic variability, which is increased with basal and bolus insulin. Furthermore, you see that the initial description for brittle diabetes was there for long-standing type 1 diabetic patients. And in these patients, it is seen that if you use pumps, they have a better glycemic control with lesser glycemic variability. She also said there is inertia in the part of practitioners more than the patients. So here you see where the deficiency lies. It's in us. So if we prescribe pumps to the patients in the first place, they will have a better control, leading to lesser complications. She talks about the advantages of pump. However, it has certain cost limitations. I do agree. Patients are not educated enough. But again, that's the part on us. It is our onus to teach them how to take insulin pumps and how to correctly insert it and use it in the first place. Is there increased incidence of decay because of tube block or malfunction? Well, you do have a CGMS machine which is checking the plasma glucose values. You do have multiple SMBG monitoring if you use an open loop pump, which is relatively cheaper. If you see rising plasma glucose values, you can go to your practicing physician before the decay sets in. Furthermore, cost. As the judges have already said, that we are not a third world country anymore. As per the World Bank, our per capita GDP is 1.4 lakh per year, and which is increasing. Only because of the pandemic, there was a slight dip, but it is increasing. It is user friendly. Now, if you look at athletes, what would they prefer? They would prefer a pump rather than insulin. And in my experience, I have certain people who are rickshawalas or like laborers. They say they cannot take regular insulin in the afternoon. So what will they do? However, if we can teach them the complications will far outweigh the problems, then they will switch over to insulin, especially when it is for 1 lakh rupees for the open system. Thank you very much.
I agree with Dr. Avasthi in what he said, that the flexibility of dosing is very much important and one of the main advantages of an insulin pump, and very much required for young adults with erratic life habits, increased variable physical activities. So these are the advantages of insulin pump. But I would not say that in our country, either it is not possible or it is mainly because of the insurance coverage and other things which is not available in our country, that insulin pumps is not being used to a large extent. And the 4 pillars of diabetes treatment, it is not only insulin, it is mainly the meal timings, the physical activity, and then the pharmacotherapy and the self-monitoring of blood glucose, which is very important. So it is not only an insulin modality device, it is all the 4 pillars which contribute to the management of type 1 diabetes. Thank you.
So excellent presentation by both. I think both of you have defended your sides very well. So one side is the insulin pump of giving insulin, other is the basal bolus insulin therapy. What is the take of both of you on role of SMBG, maybe 4 or 6 times a day, versus the CGM in the setting of type 1 diabetes? I'd like to take views, both of you, starting with you, ma'am.
CGMS is a technique of detecting the interstitial fluid glucose. Every 5 minutes we get the readings, but it has to be taken with the help of the patient should also have these a reader, and he should flash it on the sensor device, and then only these values are going to get registered. But if you take an SMBG, it is like you get the immediate recordings of the blood glucose, but it is more painful. It is more you take a lot of jabs on the same day, which is very difficult for the younger age group who are going to office, who are going to schools. So they have a very hectic lifestyle. So for those patients, SMBG is not a better option. CGMS is much more, it is much more preferred. But of course, there is also a high chance that hypoglycemia, they are not very sensitive to hypoglycemia. CGMS have that disadvantage also. So I would say that both of them have their own advantage, disadvantage. CGMS is much more preferable in the patients with type 1 diabetes mellitus. But of course, it may be insensitive to very low ranges of blood glucose.
Thank you so much. Your take, please.
So I have 2 takes. If you ask me the first take, which is all or none, then I would say that CGMS is better. However, if you ask me what I would do practically, I would say that for the initial phase, when we are looking at the TDD and how we are administering insulin, probably for 2 weeks, do a CGMS, then keep it off for at least 3 months or so where you do SMBG. And if the patient has rising plasma glucose values, or if in spite of having a fasting PP, or if they're only doing twice or thrice SMBG with a very high HbA1c, I would then again introduce the CGMS to correct the insulin, teach them the technique again. So I would try an intermittent CGMS in between SMBG. That would be the second answer, but all or none would be CGMS.
So just I would like to add here that even if we are using a CGM device, there are different types. One is a Medtronic device, which needs to be calibrated 4 times a day, right?
Yes.
So, and there is the Libre device, of course, which is a different technology. You are right, in the Indian setting, especially in Indian summers, the Libre are having some issues with the reliability. But the whole idea of using it, that they don't replace each other, they're complementary. In patients who are facing glycemic variability, who comes with SMBG values are pretty good, and the HbA1c continues to be high. There's a HbA1c SMBG discordance. In them, short-term CGM really helps us in picking occult hypos and hypers.
So with this knowledge in the background, in the patient that you described, the unfortunate girl with complications, reasonably good CBG values, capillary glucose values, but high A1C, would you like to use an insulin pump, or would you like to use a CGM device?
So we used a CGM device. We saw there was a lot of variability in this subject of ours. So we have told her about the insulin pump. She is saying that she will, because right now she is getting meropenem because she is only sensitive to
That is
meropenem, but she will consider it after discharge.
So now you said that subcutaneous insulin has a lot of variability, basal bolus.
Yes, sir.
So when you're using a pump, you're also using subcutaneous insulin in a basal bolus fashion. So where is the difference between a pump and a pen in terms of basal bolus subcutaneous insulin?
Sir, in the, do you want?
Both of you can answer.
Okay, sir. So in the form of pump, we have a rapid acting insulin, which is being introduced every hourly. And when we need a bolus, there's a higher dose. And it has been seen that rapid acting has a variability of around 3%.
No, I'm saying that you're using a basal bolus insulin when you're using a pump. You're using a basal bolus insulin when you're using a pen or a syringe.
So I'm talking about the subcutaneous absorption.
Both of them are using a subcutaneous approach.
Yes,
so how do you think they're different?
It is automated, sir. The insulin pump is automated.
So automated, so
it's more precise.
suppose
delivery.
before a meal you give a bolus with the pump, you press a button. When you use a pen, you just press the plunger of the pen, piston of the pen. So how are they different?
So what I'm trying to state is that the amount of subcutaneous insulin which is absorbed based on the various insulin preparations differs. The variation.
Both of them deliver insulin to the same space.
Sir, but the variability of absorption and action varies
The
from
absorption is
insulin.
similar. So
Sir,
what is different? There's something which is different actually, because of which you pay a lot of price and because of which possibly you get some better A1C control.
Sir, there is a variation in the subcutaneous absorption of the insulin, which is around 50% for NPH, 16% for regular insulin, only 3% for rapid acting insulin. And here in pump, we are obviously using rapid acting insulin.
So when you're
Component is benefited more, the basal component or the prandial component?
That's a hint
Sir,
there.
in this, the basal component is the basal component is being ignored.
The flexibility of dosing with, we can plan for the food intake. We are going to give a bolus
Have you
dose.
heard of something like variable basal dosing
Yes, sir.
or
Yes.
square wave
Yes,
bolus?
sir. Yes, yes.
So I'm
Yes,
not
Different
mentioning
types of bolus, super
Yeah.
bolus,
So I'm not
extended
mentioning
bolus.
those are
We
the
have different types of bolus.
Okay, good, well done. Yes or no? No. No. So your opponent speaks first.
Kindly introduce yourself and repeat the topic first. Name, topic, and then start.
Very good morning, respected judges and my fellow participants. My name is Dr. Devaditya Das. I'm from IPGMI, Kolkata. My topic is that every hypertensive person should be screened for secondary endocrine causes. I'll be speaking for the motion today. We all know the saying that when you hear the sound of hooves, search for horses, not zebras. But as endocrinologists, we know that many a times the sounds do come out of zebras. So we always should be very aware and for the lookout for these rare zebras. Regarding the topic of screening, which diseases should be screened? Disease which has to be screened has to be very ubiquitous in the population. There has to be a simple screening test to pick that disease up, and there has to exist a cheap and very effective treatment for the disease. And I think that endocrine causes, especially the cause of primary aldosteronism, meets all these three criteria. In recent studies, we have seen that treatment-resistant hypertension and certain secondary causes of endocrine hypertension are very, very much common. If I quote the data from the ENHANCE study, it has showed that there are 53% hypertensives who are treatment-resistant. In the Framingham Heart follow-up study, the percentage is 48%, and in the ALLHAT study, there is almost 37% of the population who are treatment-resistant. And if we see the global figures for hypertension, there are almost 1.39 billion people living with hypertension all over the world. And this hypertension, this figure is just an iceberg phenomena. If we go back to our PSM days, the Park's textbook of PSM had actually a Venn diagram where it showed that only 50% of all the hypertensives are screened and picked up. Out of them, only 50% are treated. Out of them, only 50% are treated adequately. So we know how much we are missing out on. So keeping this in mind, we as doctors and endocrinologists, we have to be proactive and not reactive. study by Dr. Anand Vaidya showed that even with all the high risk factors, with all the high pretest probabilities, only less than 3% of hypertensive were screened for primary aldosteronism. That too, when easy screening modality is there. Some might argue that screening is not enough and you have to do confirmatory tests and then imaging and then maybe localization. It's a long road. But I would argue that even in some cases where the plasma aldosterone levels is more than 20 and the PRA is suppressed below 1 and there is hypokalemia, we can easily skip the confirmatory test and go for the final steps. And if the age of the patient is less than 35 years, we can directly go for surgery. Not only that, some might argue that secondary causes should not be screened and simply medical therapy should be offered to everyone. But I would like to disagree. In certain specific cases like primary aldosteronism, there are direct effects of the mineralocorticoid hormones on different organs, like the heart, where it can cause myocardial fibrosis and other effects which might be deleterious in the long run. And there exists a permanent cure for these kind of conditions like primary aldosteronism, where the patient can be cured of this disease once and for all. And also, if surgery is not possible for the disease, there is a specific medical therapy, and we can actually adopt that instead of just going on with one hypertensive after the other. So the diagnostic inertia should be addressed by us. And truly speaking, the true prevalence will only be known if we screen and screen. We can't know if we don't screen, we can't know the true prevalence. So already, as I quoted, there is less awareness in the primary care physician, which ultimately leads to pill burden and polypharmacy, which ultimately leads to people forgetting to take their antihypertensive medicines. And like if you prescribe someone 4 or 5 antihypertensive medicines, they are bound to forget one or two of them. So that is not the right approach, I feel. Coming to some of the younger hypertensive population, as we know that time and again, with passing time, the younger hypertensives are increasing number. And a study by Dr. Sara Alam et al. From New Delhi AIMS showed that almost the prevalence of primary aldosteronism in these population are 28%. So if we don't do that, we might miss these people. Like in India, we have a chalta hai culture. Theek hai, hypertension hai chalta hai, thoda dawai le lo theek ho jayega. We must get out of this rut. We currently are living in an era of precision medicine. We cannot just give antihypertensive randomly to everyone. We have to specify why the hypertension is happening, especially in young hypertensives, and address it accordingly. Just saying that the screening cost is high or it is not affordable for everyone in India, I feel that this cannot be an excuse. The cost has, come down a lot compared to the past, and we should employ the screening tactics in almost everyone. And another thing is that if it was very easy to pick these endocrine causes up just by looking at them, maybe from the history or from the clinical examination, maybe we could have scrapped the screening test part away. But then you cannot pick that up. Pulmonary aldosteronism especially don't have a certain phenotype. And even with many of them don't have hypokalemia also. So in those cases, only 30% may have hypokalemia. For the other 70%, what are we going to do? If there is no hypokalemia, we won't screen. So in this case also, we should screen. If I talk about the rising incidence of adrenal incidentoloma, we might find a tumor sitting on the adrenals due to diagnostic improvement in diagnostic modalities. We are picking it up more and more. And in that cases also, there is a significant proportion where there might not be any stigmata for Cushing's syndrome, but there might be mild autonomous cortisol secretion, which can be a cause of hypertension in that patient. And if we just remove the adenoma, we can actually cure the patient from the hypertension. Finally, I would like to say that with evolving time, there will come a future where the so-called essential hypertension will be actually replaced by primary aldosteronism as the most common cause. Once upon a time, we used to think that primary hyperpara is very rare, but now see how many primary hyperparathyroidism cases we are picking up. Similarly, if we continue on screening, we can actually get rid of certain very sinister complications in the populations, like 4 times hypertensive have 4 times the risk of stroke, 6 times the risk of AMI, 12 times the risk of atrial fibrillation. So if we screen for primary aldosteronism and certain other causes, like the other endocrine causes like Cushing's syndrome, low renin hypertension, hypothyroidism, hyperparathyroidism, etc., we can actually give precise treatment to our patient population. So yes, I would think that all hypertensive should be screened for endocrine causes. Thank you.
Good morning, respected judges and all my dear colleagues. Dr. Debaditya is very well told about the endocrine causes of hypertension. First of all, I would like to reflect a bit about the prevalence and burden of hypertension. Hypertension is a huge burden disease similar to diabetes. Rather, I would say it is much more prevalent and much more prevalent than diabetes. And in the UKPDS trial, it was seen that the control of hypertension was much more impact in controlling the complications. We have seen with rise in 20 mm Hg of systolic blood pressure and 10 mm rise in diastolic blood pressure doubles the mortality because of ischemic heart disease. The overall burden of hypertension worldwide is huge. It is around 30 to 40% of worldwide population is affected with hypertension, which accounts for nearly 1.3 billion population. And of this, 10.6 million population have an annual mortality rate. In India also, the prevalence is very high, around 30%. And around 1.6 million Indians every year die because of the complications of hypertension, leading to stroke or any cardiovascular disease. I agree with him that there are secondary causes of hypertension, but secondary causes of hypertension are only present in 15% of the cases. We should not forget in looking at these 15% cases, the primary cause of hypertension is still idiopathic primary hypertension. So in order to look to treat in these 15% of cases, we can't subject all patients of hypertension to these unnecessary tests, which would be unethical. When we talk about only secondary hypertension, the majority of secondary hypertension burden is borne by the renal vascular diseases. There are few causes of cardiac conditions like coarctation of aorta or aortoarteritis. Endocrine causes just amount for 5 to 7% of these. When we look at the endocrine burden disease across the spectrum of diseases in our society, endocrine diseases are present in rarity as compared to other diseases. My colleague talked about the primary hyperaldosteronism. I fully agree with him that around 10% of the hypertensive patients are having primary hyperaldosteronism. And I also agree with him that 70% of patients are normocalemic. Most of the hyperaldosteronism patients are asymptomatic. There is no signs and symptoms. They only present typically as a primary hypertension. So, but for these mere amount of patients, should we screen all the patients? I don't think this is a justifiable answer. There is increased risk of mortality. There is increased cardiovascular disease with hyperaldosteronism, but these patients could be followed up for the regular BP monitoring for next 15 days, once or 2 months. And if the blood pressures are not getting controlled or requirement of antihypertensives is progressively increasing, these patients can be screened for the primary aldosteronism. Then he talked about Cushing syndrome. He talked about pheochromocytomas. The Cushing syndrome and pheochromocytomas are very rare disease. The prevalence of pheochromocytoma is 2 to 6 million cases per million. And the hypertension is the most common symptom present in those. But hypertension as a sole manifestation is absolutely rare. It's just like searching a pin in a field of grass. Hypertension is associated with either protein catabolism features in Cushing syndrome, or there will be episodic palpitations, tremors in cases of pheochromocytoma, postural dizziness, or other signs would be present. In order to treat only these rare causes, which accounts for less than 1%, I would say, subjecting whole 95% population to these costly tests is not justifiable. Secondly, I would also like to say that acromegaly also have 35 to 50% of hypertension, but even after treatment of acromegaly, hypertension is not cured. Even the thyroid disorders like Graves' disease or thyrotoxicosis have 33% prevalence of systolic blood pressure. But the patient of thyroid disorder does not present with hypertension mainly. They present with weight loss, tremors, palpitation. Those patients presenting with only hypertension like apathetic thyrotoxicosis, these are mainly elderly patients above 60 or 70 years of age. He also talked about primary hyperpara. I do agree primary hyperpara is increasingly recognized nowadays, but primary hyperpara has 40 to 80% prevalence of hypertension. But hypertension in primary hyperpara is very late appearance. The hypertension reason is because of the hypercalcemia induced nephrotoxicity. The patients before that present with fracture, renal colic, or pancreatic calculi with abdominal pain, multiple bones pain. I would like to say the Endocrine Society guidelines have given few guidelines to which patients should be subjected to these tests. The patients include the patients having history of resistant hypertension, the patients are requiring 4 or more drugs to control the blood pressure, the patient is having persistent blood pressure of systolic of above 160 and diastolic of more than 100. There is a family history of young hypertension, or there is a family history of pheochromocytoma or primary aldosteronism, or patient is having unilateral adrenal mass or bilateral adrenal mass, as was talked by my colleague. Secondly, on the cost issue, I would like, on the basis of testing issue, as he said, the testing is widely available nowadays. I do agree the testing is widely available. The assays have improved, diagnostic yield of the test has improved, but still the cost of test is very high. In our country, we can't omit patients wearing the cost, because in our country, the cost is borne by the patient's pocket itself. The insurance company or nobody else supports the patient. So testing each and every one with around 15 to 20,000 cost of endocrine diseases searching is not feasible when you are looking for only 2 to 3% of the cases. Secondly, he talked about the primary care physician, and he talked that there is less knowledge about these. Apart from endocrine, the primary care physician, even in the tertiary centers, don't have the knowledge of pre-analytic measurements of how the samples have to be taken, what dietary restrictions patient have to follow, how the sample has to be taken in the morning, in the evening, what methods has to be followed. So the yield of these tests still becomes much poorer if not done in the proper manner. So to summarize my points, I won't accept this part that every hypertensive patient has to be screened. We should bear in mind that 85% of the cases are idiopathic hyperthyroidism. Endocrine cases comprise only of 5 to 6% of the cases. Majority of endocrine cases present with the florid symptoms also. Only for few minority of the cases which comprise of 1%, whole 98% of population should not be subjected to the highly costly endocrine tests. Thank you.
Good morning again. It seemed that my good friend Ankit was reiterating my points and making my points stronger in his speech. He said that he quoted certain figures of prevalence of hypertension, which is very ubiquitous in our world today. And the percentage of endocrine hypertension was, according to him, very less, around 5 to 7 or maybe 10%. But just factor in 10% with 1.39 billion people with people living with hypertension. You can just calculate simple math. You can see how many people are struggling for, how many people might be struggling from secondary causes of hypertension, especially endocrine hypertension. And this, as we all know, is a very, is an underestimate basically. And I think there is an issue with cost. The screening is a bit costly, but I feel that no cost should be too high for a healthy life. My friend also said that the cure rate is basically low. Even if we find certain secondary causes of endocrine hypertension, ultimately we have to resort to medicines. The permanent cure is not that much high. But I don't think this can be an excuse not to screen people. We should work on how we can make the cure rate higher and higher, rather than just saying, okay, the cure rate is very low, so we should resort to the old way of treating hypertension. Regarding the topic of hyperparathyroidism, I think my friend might be confused. I used hyperparathyroidism just as an example to state that how a rare disease can become not so rare by proper screening and proper testing, not as a prominent cause of hypertension. It was used, and I think that taking all these things into mind, permanent cure rate is low, cost is too high. I think we should push for a public policy so that people can be taken into under medical insurance and everything can be provided to them, rather than saying that cost is low and we should not do screening. We are living in an era of precision medicine, and whatever treatment we institute should be based on evidence and not just based on personal experience or anything we like. Thank you.
Thank you, Devaditya, for your feedback. I would like to comment on few points. Earlier, Devaditya talked about the prevalence of resistant hypertension. I agree with him. Every case of resistant hypertension has to be screened for endocrine causes because in those patients, the prevalence of endocrine causes are much higher. He also talked about the prevalence of primary hyperaldosteronism in AIMS, 28%. AIMS is a tertiary care center where mostly difficult cases are basically referred. So there could be a bias in diagnosis of the prevalence of primary hyperaldosteronism could be much higher as which is present. Talking about the prevalence, he is told that 5 to 7% prevalence accounting to in our country would be around millions of people. I do agree with him. But what I wanted to say, prevalence is 5 to 7%, but of this 5 to 7%, 3 to 4% population have florid features of secondary endocrine causes leading to hypertension. I was concerned about those 1 to 2% of population which have only presentation as hypertension, and treating to find those patients, subjecting each and every patient to the endocrine causes is not ethically correct. Thank you.
There is a parable in the Bible. If you have 100 sheep in the
Bakri.
But the point is, you have 100 sheep and one goes astray. Will you let that sheep go? What will a good shepherd do?
We will use the stick and again move her in the herd.
The sheep is lost. You have to go and find it. When you think about it, you are doing PM endocrinology now. To your mind, what is the single difference which will distinguish you from an LD medicine?
I would say that to have a clinical eye to pick up certain things which are supposed to be esoteric but are not that much rare.
Index of suspicion, where she had only
have 100 sheep and one is lost.
Yes, sir.
So what is the answer? Is also there in the Bible.
Yeah, I will go looking for the sheep, because if this goes on, I mean, in the long run, it will cause the loss of even more sheep.
What are the symptoms and the signs which will tell you to suspect secondary hypertension? Just symptoms and signs.
So there could be resistant hypertension. Patient is requiring 3 or more antihypertensive. The resistant hypertension is patient requires 3 antihypertensive at maximal doses, and one of them has to be a diuretic.
No, not exactly. Is not well controlled with 3, out including one diuretic. That is the difference. Requires 3 though.
Not well
controlled on 3. Not required. Okay. Yeah, is not well controlled on 3, and then refractory.
The patient is requiring 4 or more antihypertensive.
5 or more, not controlled with 5 or more, with tolerable doses of 5 or more, and with diuretic.
The etiology of refractory and resistant, is it the same or is it different?
Treatment resistance is much more prevalent compared to.
Does your approach differ?
They do, sir. If there is refractory hypertension, I should be more proactive in screening certain disorders. And
like what is the etiology? What is the autonomic dysfunction? What is the etiology of refractory?
Sir, like catecholamine secretions, pheochromocytoma, catecholamine secreting tumors, those can cause. And also, Conn syndrome can also be one of the.
Is the etiology the same or is it different?
It is different.
Which category you would like to search for secondary hypertension?
In between these two, I would take refractory hypertension. I would be more proactive in searching for secondary causes.
Should be more aggressive.
Yes, sir.
What is autonomic hygiene?
Autonomic hygiene.
What are the parts of the autonomic nervous system?
Sympathetic and parasympathetic nervous system and enterohepatic.
How do you balance them?
by keeping a like cool and calm mind to rest our mind so that we don't go up and down like well.
Let's do that and then tell us one point which your opponent should have mentioned, but he missed. Put yourself in this.
If I was speaking against the motion, I would have reiterated the points thing that the not screening doesn't lead to anything, and there has to be, I mean, there are multiple facets to the story, like confirmatory tests, imaging, localization, which are not at all practical or feasible in all the centers. So this is one point I think he should have put more emphasis on.
Sir, I would like to say if we don't screen these patients, even a single patient of hypertension, then we won't able to know what is the prevalence of the endocrine causes.
What is the difference between you and the physician? If the endocrinologist will not screen for endocrine hypertension, then who else will screen? That was like a parallel I asked you. But it's not too much of a religion, but I think all of you will be using that parable multiple times in your life. And I hope you remember that fondly.
If I may add, sir, as endocrinologists, I think we are the end point. The buck stops here. So we have to screen. If we don't screen, no one will screen.
Thank you.
Yes. So you are against the motion. John, you are against the motion. What's the
Name and topic and then
Good morning, my respected teachers, my respected seniors, and my dear colleagues. Myself, Dr. Piyash Gargori from IPG Mere Kolkata, will like to use this august opportunity to stand for the motion that bilateral adrenalectomy is the best choice for idiopathic ACTH-dependent Cushing's syndrome. Okay. So let me put a proverb first. Let me put a quote. A surgeon will cut off a limb in order to protect the body from disease. And a commander-in-chief should pull out of a war that cannot be won in order to protect a nation. The same is here. We are dealing with an idiopathic disease whose etiology has not been found despite extensive search. We do not know, is it from pituitary or is it from the peripheral side, that is the ACTH is producing. So we cannot know that what we are dealing with. So we must pull out of a ward. Now, for any treatment to advocate, we know that there are two things: that what is the benefit of the treatment, what are the downsides of the opposite treatment, and whether it is worth it. That means, is it acceptable? Is it feasible? Is it affordable, sustainable, or safe? Now, according to the Endocrine Society guidelines, latest, in patients with overt Cushing's syndrome, we recommend normalization of cortisol level in its action or its receptors to eliminate the signs and symptoms of Cushing's syndrome and treating comorbidities associated with hypercortisolism. And when a definitive surgery is not possible, the second line is to depend on the patient's preferable treatment goals, biochemical control, and the surgical expertise, drug-drug interaction, and personal history of choice, and whether that therapy is available. Now, let me remind you that Cushing's presents in two forms. One is that is in elective setting, and the other is that emergency setting. And we are mostly will focus our attention to the elective setting, but let me remind you, it can be emergency as well. Now, for bilateral adrenalectomy, I will like to reiterate my first point, that it is a safe and definitive control of hypercortisolism. That is my first point, whether a treatment is safe or not. Yes, it is safe. In the way of Opsol et al. As published in European Journal of Endocrinology in 2014, the median surgical morbidity was 6% and 4% was the mortality only. And let me remind you, it is 2014, 7 years back, that the technology has improved tremendously. And all Cushing specific comorbid conditions improved. Adrenal crisis incidence was 4.1 per 100 patient years. Okay, that's good. Now, if I reiterate another study from Rinke et al., hypertension improved significantly, diabetes improved significantly post-surgery. Cushing stigmata improved from 100% to 22%. And if I reiterate another topic, phenotypic stigmata of Cushing's reversed 85%, adrenal hypertension reversed 82%, diabetes 70%, obesity 30 to 43%, with a recurrence rate of less than 2%. And the quality of life was better, 82 to 89%. Now, the second thing is immediate control of steroid excess. Yes, it does immediate control of steroid excess, because in emergency setting, after intermediate, we have to resort to immediate bilateral adrenalectomy. Now, what is the downside of medical therapy? That is the ketoconazole. Let me put out the against players. The ketoconazole, the metidapones, and the mifepristones. Ketoconazole has severe GI side effects, also associated with male hypogonadism. And let me remind you, there is a black box warning regarding it. There is 1 in 15,000 idiosyncratic severe hepatic dyscrasias, for which FDA has put a black box warning on that, and European Medical Agency has put a restricted access to physicians on that. Canadian Society recommends that if LFT is more than 3 upper normal limit, discontinue, and as per the US, more than 30%. And there is also a risk of torsades. You don't know whether a patient is on astimazole. You don't know whether a patient is on ranolazine. It all leads to QTc prolongation. And once it is QTc prolongation, it is a fatal incident. Now, let me put out the second player. That is a metidapone. It escalates hypertension. It escalates hypokalemia. The very thing that we are going to play against. And there is frequent dosing interval. The half-life is only 2 hours. So you have to give to frequent dosing. You are going to put hydrocortisone, but again, look at it. It also has frequent dosing. Also, you are exposing a female patient to severe hyperandrogenism. It is hirsutism. And you are also putting a patient. You are going to monitor by what? You are going to monitor by cortisol. Again, there is a loophole. The DOC will put a interference in measurement of cortisol. Unless you have an expensive LC-MS machine, it is again a standstill. Now, the second thing is mitotin. It is a longer acting drug. It is adipose storage, and therefore it will lead to increased duration of action. It will lead to induced CYP3A4, that is escalate the dose of hyson you have to give. It is also a teratogen. The duration of teratogenicity, it is unknown because it is stored in the adipose tissue. Let me put mifepristone. All these agents leads to hypertension and hypokalemia. And for mifepristone, it is even worse. You cannot monitor because it is a receptor antagonist. You cannot monitor by cortisol. So again, you are standstill. You have to monitor by clinicals. Okay, fine. And let me put the latest thing, that is etomidate. It is used for ICU setting. Okay. Then what you are going to give, unless it is oscillotostat, which is recently discovered, you cannot give much more things. So there is another thing called etomidate induced thrombophlebitis because of propylene glycol. So you cannot give any things. Now let me put it in a cost-effective way. A tablet of ketoconazole, 10 tabs is 450 rupees. So you are exposing a patient to 2,700 rupees per day and 81,000 per month. And you are exposing a patient to mifepristone, that is 300 rupees, that is 270 rupees per tablet. You are exposing a patient to 400 rupees per day. Is it cost effective? No. So the cost of laparoscopic adrenalectomy is 1 lakh. And if we talk on that, the hyson tablet, it costs only 10 tabs, 32 rupees. You are exposing a patient to 40 rupees per day. Now, which is better? A tablet of which costs 81,000 per month, or one-time investment with 1 lakh rupees and followed by 40 rupees per day. So I agree here that this treatment is affordable. This treatment is feasible. This treatment is acceptable as shown in the quality of life. This treatment is sustainable and this treatment is safe. So it fulfills the FS criteria. So I keep my statement that you should consider it.
Good morning, teachers and my dear friends. I'm Dr. John T. Johnson, and I would like to use this opportunity to debate against the topic given to me, which is bilateral adrenalectomy is the best treatment option for idiopathic Cushing syndrome. So when we think about Cushing syndrome, we know that ACTH-dependent Cushing syndrome is the most common cause of endogenous Cushing's. And in about 80%, it is the source becomes the pituitary, and ectopic contributes to about 10%. And the mainstay of treatment of Cushing's this syndrome, ACTH dependent, would be to identify the source of ACTH and to remove the tumor so that we can achieve a complete cure or a remission in these patients. So what do we mean by idiopathic Cushing's syndrome is something which is very important before we decide whether adrenalectomy would be the best. What is idiopathic in one center may not be considered idiopathic in another center. It can also vary from country to country, depending on the access of or the modalities which are available to you as an endocrinologist. If you're working in a tertiary center where we have all the advanced MRI modalities which are available, including the dynamic pituitary sequencing, the pickup chance of a ACTH producing pituitary microadenoma would be much higher than if you're working in a peripheral setup where the quality of MRI is not the best. And coming to an ectopic Cushing's syndrome, if we are using CT or an MRI as the only method of identifying a source of ectopic ACTH, the chance of us missing up on many other causes of or the tumors producing ectopic ACTH would be higher compared to a center where we have access to the advanced functional imaging modalities, including the FDG PET or the gallium dotatate scanning. And also now there are more research coming saying that there are more additional functional images, especially like the gallium DOTA CRH imaging. And these have helped in identifying even the minutest of the pituitary microadenomas, which could be the reason for their ACTH excess. So before we decide what is the best treatment, it is very important to assess our clinical scenario and then rediscuss it with the patient and the other treating team, and then choose about the imaging modality. So that would be my first argument against the using the term as adrenalectomy being the best treatment. And what are the other concerns about an adrenalectomy? We have to also assess this indication for which we are choosing adrenalectomy. Most of our Cushing's patients come to us as an elective admission or an OPD visit, and it is only a minority of them who come to us with the emergency indication. By emergency or catastrophe, I mean to say that those people who are coming with uncontrolled hyperglycemia with the ketoacidosis, or they're coming to us with bacteremia and sepsis, or they come to us with a significant GI hemorrhage, they are having significant psychosis related to it, or they have refractory hypokalemia, hypertension, heart failure, thromboembolic events. In these situations, yes, probably we don't have time for the other modalities of treatment, and hence emergency bilateral adrenalectomy may be warranted. But think about the majority of our Cushing's patients who are coming to our OPD. We still have time. So this time has to be used wisely to use the appropriate modalities for identifying the source of ACTH. And this time can be used for managing the patients medically. So medical treatment still has a valid role in the treatment of any form of Cushing syndrome. And the timing of surgery has to be chosen appropriately and not as the best in every scenario. And also we will look at the problems which are associated with adrenalectomy. As Dr. PS have rightly said, with the advancement in the surgical modalities, converting from bilateral open adrenalectomy to the laparoscopic approaches, the morbidity and the mortality has come down. But still, after adrenalectomy, the main long-term complications what we worry about are one, development of Nelson syndrome, which is now referred to as a corticotroph tumor progression after adrenalectomy, and the second one being the adrenal crisis. Coming to the first complication, that is Nelson syndrome, definitely the definition of Nelson syndrome over the years have evolved compared to the initial study by Dr. Dawn H. Nelson of a 33-year-old lady who had presented 3 years after adrenalectomy with hyperpigmentation and a large tumor, which was picked up on X-ray because the MRI facilities were not available. And the assays used were also different. Now, I agree that we have advanced imaging modalities, newer assays which are available, which helps to identify these Nelson's people more. So the prevalence, if we look at the Nelson syndrome compared to the initial data prior to 1990, compared to the data which are coming subsequently, there are more and more number of Nelson's patients who are identified after an adrenalectomy. And we are mostly focusing on the corticotrophic tumor progression, but can the same mechanism happen in other ectopic sites as well? So the guidelines are very clear, saying that initially at 3 months and subsequently at 6 to 12 month interval, we have to monitor patients for development of Nelson syndrome with an MRI and clinical assessment. But what about the imaging modality which we choose for following up an ectopic Cushing? How frequently are we going to monitor them? What imaging modality are we going to use for screening? Are we going to use a gallium DOTA? Are we going to use an FDG PET? Is there a possibility that even this can worsen and may not be identifiable? We have come across a patient with a bronchial carcinoid who had undergone bilateral adrenalectomy and subsequently came to us with a large tumor, which was picked up much later. And also, what is the impact of this on the quality of life? Especially, I mean about the adrenal insufficiency, because there are data suggesting that at least 25% of people after bilateral adrenalectomy can have at least one episode of significant adrenal crisis in their long term. Hence, choosing a surgical option as the best is a very relative term, and it has to be used with caution. It has to be discussed extensively with the family and the other imaging modalities which are available. Preferably consult with your colleagues, discuss with them about what additional techniques can be used before we make a major decision like subjecting a person to bilateral adrenalectomy. Because once we do that, there is no going back. So I would conclude by saying that we cannot say bilateral adrenalectomy is the best. It can be chosen in certain selected indications, but generalizing it as the best treatment option for idiopathic, the so-called idiopathic Cushing syndrome, is a very dangerous term to use. Thank you.
Thank you. Thank you everyone for giving me a second chance. I would first congratulate my worthy friend, Dr. Johnson, to bring it so good points. But doesn't that actually strengthen my views? Actually, what the topic was idiopathic ACTH-dependent Cushing syndrome. That means we have extensively evaluated and no cause has been found, as has been seen in commonplace. So he has told that one center's idiopathic might be center, other centers not idiopathic. True, yes. But just let me give an example. In our setting, there was a patient who was initially detected as idiopathic Cushing syndrome, ACTH dependent, who was later detected to have pituitary adenoma, resected twice, one in 2011, one in 2014, relapsed. And that landed up with bilateral adrenalectomy. Now, for the second point, he has told regarding Nelson syndrome. Yes, Nelson syndrome is a possibility, but doesn't the guideline is too succinct how to monitor for it, how to monitor for imaging, and how to monitor with a simple biochemical test? Yes, it's crisp. And nowadays, previously, it was used when Dr. Nelson in 1958 was diagnosing, it was a cellular X-ray. But now look at it. Almost all the cities have MRI. Even the poorest of them can afford it from a government hospital. Okay. Now for the ectopic Cushing's. For the ectopic Cushing's, are we spending too much amount of money and too much radiation for searching the source? And is it not much more feasible, according to FAS criteria, to put out the war, to put out the fire that is within? Because we have to reduce the complications that the patient is facing. We have to reduce the comorbid conditions. So by this, I would like to conclude my views on forward notion. Thank you.
So I will give a few points which came to my mind, especially during this rebuttal session. So the question which was raised was, is it worth spending money in searching for a source of ectopic Cushing because we have already poured water on the fire? But the source of ectopic Cushing's can be multiple. All the sources cannot be as indolent as a bronchial carcinoid what we see. There are more aggressive forms, especially the thymic carcinoids. So the thymic ones, these neuroendocrine tumors have a potential to metastasize. So initially they would have presented as only ectopic Cushing's as the manifestation, but subsequently they can metastasize to other organs, and hence identifying the source of ectopic is definitely important, because a patient can present with life-threatening bleeding from the pulmonary carcinoid, or it could be metastasized to any other organs in the body, which can have a significant impact on the quality of life. They can continue to produce other ectopic hormones. So definitely screening for any source of ectopic Cushing's is warranted. We cannot always say that, okay, I have taken out the adrenal, so that is the end of it. And also, in any elective situation, before we make a decision of a bilateral adrenalectomy, it is very important that we discuss the pros and the cons with the patient. The patient should understand that we are only taking out the adrenal. The hormonal excess has been taken care of, but the primary is still inside. Isn't that important to be discussed with the family? Can we use the term, this is the best treatment for you? I would not agree with that. This is definitely not the best. Probably that is the one which is available to us at that point in time, but the best treatment may evolve over time. Thank you.
Dr. John, I like the way you presented your softness, but somewhere I'm not satisfied with the content of your topic on which you have to speak. You said that it is not the good option, but what is the option you are presenting? What is the thing which you are advising, advocating that, okay, this is the option and this you have to do? You have negated everything about that surgery is not a good option. What will you do? What should be done?
So the final take in this topic would be that once we have screened and ruled out all the other primary etiologies, and we still haven't been able to find the etiology of the Cushing's, maybe adrenalectomy have to be done. But whether we can use it as the best modality is still debatable. Definitely at this point in time, that would be the ideal thing for that particular patient. But I would mean to say that we should use the time when it is not an emergency surgical intervention, start them on medical management, reassess them, how they are progressing. Are we getting any more clues for the primary disease? And if there is an emergency indication, or if the patient is not tolerating the medical option, definitely we don't have an option but to go ahead with the adrenalectomy.
Where then you are joining him.
Yes, at the end, we may have to go with adrenalectomy.
You are surrendering and you are joining him.
So
you have not focused at all on any of the medical aspect, or okay, if you are not going for surgery, you need to treat the patient. You are again returning back to the screening point, but no option you are mentioning about the management. So that's the point I wanted to raise. So you should have focused more about the other alternative modes of management rather than going back to screening. Thank you.
We have the final set of debaters.
one of them. No, so you speak first.
Name, topic, and further motion.
So good morning, one and all, respected judges, senior faculty members, and my dear colleagues. So I'm here to speak for the topic, metformin should be the first line treatment for type 2 diabetes mellitus patients. So metformin has over the years evolved as one of the favorite medication for a primary care physician as well as endocrinologist for the management of diabetes mellitus. I would just start by briefly mentioning about the history. So metformin was first found to have a glucose reduction potential in the 1920s, and it was firmly established in the 1950s by Dr. Stern. And it was during that decade itself, metformin was used commercially in France, initially in the Europe, and later America adopted in the 1990s. So in the late 1990s itself, metformin has started to find its place among the essential medicine list of each country. And by 2010, it is really in the top of all the essential medicine list in each of the countries. So now, what are the ideal attributes for a good anti-diabetic drug? So it should have a good effect on the glycemic control. It should address the pathophysiology of diabetes. Third, it should have the cardiovascular safety. It should have renal safety. It should promote weight loss. Then it should be affordable as well as available. And it should have very less adverse effects also. So I'd be dealing with each of these points with respect to metformin. First, regarding the glycemic control. So the studies have shown that after insulin, which has, of course, has got an unlimited potential in reduction of HbA1c, metformin is the drug which has shown maximum glycemic reduction potential with an A1c reduction of around 1 to 1.5%. Next, addressing the pathophysiology. You know, for treating diabetes, you may think that why insulin is not the ideal treatment, because type 2 diabetes is not a situation where the insulin is deficient. So we have to address the pathophysiology, which is the insulin resistance. Here, metformin acts as an insulin sensitizer. It decreases the hepatic gluconeogenesis. It reduces the substrates by inhibiting the mitochondrial glycerosphosphorydehydrogenase, and it activates the AMP kinase pathway, so whereby it promotes an effect which is similar to that of what exercise is giving. It acts on the gut, it reduces the glucose absorption, it promotes the good gut bacteria, which will promote the GLP-1 release, thus it promote the incretin activity. So all in all the mechanisms of action are correctly tuned or finely tuned to address the pathophysiology of the diabetes mellitus. Now, regarding the cardiovascular safety. So after the 2008, where the record trial has the reported increased myocardial infarction events with rosiglitazone, FDA has made it mandatory that all drugs before introduction into the market for diabetes mellitus should undergo the cardiovascular safety outcome trial. But even before that, metformin has proved itself, its merit and its mettle as being a cardiovascular safe drug. The first evidence comes from the landmark UKPDS trial itself, where the comparison of the metformin versus the diet group alone has shown a significant reduction in the overall myocardial infarction, the death due to cardiovascular cause, as well as the overall mortality rate. So the follow-up studies on cardiovascular, the HOME trial, where it was studied against placebo, as well as the SPREAD-IMCARD trial, where it was studied against glycoside, has shown that metformin has got significant reduction in the cardiovascular outcomes. So one thing which makes metformin different from the SGLT2 inhibitor is that the SGLT2 inhibitor is effective only if the patient is belonging to the high-risk category or they already have developed an ACVD. But here in these studies, metformin has been found to be useful even in those who didn't have a prior history of cardiovascular adverse events. Now, regarding the renal safety, initially, of course, there were concerns regarding the use of metformin causing certain events like the metformin-induced lactic acidosis, which has been proven wrong because the incidence of lactic acidosis is as low as around 2 to 3 per 1 lakh person years of metformin treatment. So the risk of lactic acidosis with metformin is negligible, we would say, in clinical practice. And of course, you'll have to exercise precaution in avoiding metformin to persons who are having EGFR less than 30 or who are undergoing radio contrast studies also. Then, regarding the weight loss potential, metformin has been found to have a significant weight loss, or at least it remains a weight neutral. So it has a favorable effect on that aspect also. Now, regarding the affordability. So I think there is no question regarding the affordability as well as the availability of metformin, because it costs just a rupee or a value under 1 rupee for one metformin tablets, whereas the other competitors that we have, the other alternative options that you have could be an SGLT inhibitor. It would cost 15 to 20 times higher. The oral semaglutide, which has been recently given, which is more 100 times more costlier than metformin. And the injectable GLP-1, again, which costs the patient around 5,000 to 10,000 per month for a minimum dosage. Even the starting dosage would be around 25 to 50 times costlier than metformin. So whether the benefit of metformin is limited to diabetes alone, because diabetes is not a disease which occurs in isolation. It occurs along with obesity, the metabolic syndrome, the hypertension, the non-alcoholic steatohepatitis, and in fact, metformin has been found to reduce the liver enzymes, the liver inflammation, as well as the liver fibrosis to an extent in the TONIC trial. So again, and the extra glycemic effects of metformin is not limited to that. So it has been tried to reduce the risk of cancer by inhibiting the mTOR pathway. It downregulates the mTOR pathway, and there has been a link with the diabetes and increased overall cancer risk. So metformin has been strongly linked in the reduction of the pancreatic cancer, the prostate cancer, as in the METAL trial, and also in certain brain cancers. So it is at that aspect also. And also, metformin has got an anti-aging potential also, which could again reduce the overall the reactive oxygen species burden in which occurs cumulative in a diabetic patient. So again, it benefits on that aspect also. So concluding all my things, metformin ticks every boxes with regard to what an ideal anti-hyperglycemic drug or a drug for a diabetes mellitus requires, and hence that is exactly the reason why the ADA in its first statements in the algorithm for treatment of type 2 diabetes, lifestyle modifications and metformin should be the first line treatment for patients, all patients with type 2 diabetes, and then only the stratification comes, whether the patient has ASCVD, doesn't have ASCVD, mild or moderate risk, whatever. So irrespective of the patient risk profile, I believe metformin should be the first starting point in the treatment of type 2 diabetes mellitus. So I'm eagerly interested to see my fellow Dr. Sethu's talks also. Thank you.
May I begin? Yeah. Good morning, respected faculties, and I'll be presenting my last talk for the debate topic. And my friend Dr. Karthik has introduced the topic, but I'm just going to reiterate the topic once again because of a very important point. Metformin should be the first line treatment for type 2 diabetes. The word here was should, and I would like to get back to it again and again because that was the crux of the topic. So just a brief, going back to the entire scenario, that it is metformin is a bioguanide. It was, like he said, Dr. Stern isolated it in 1940, put it in market as glucophage. In 1995, FDA approved it as a treatment of choice. 2005, ADA came up with the first standard of care, said that this is the first line treatment. 2012, WHO put it in the essential list of medications. And in 2022, we are debating here at ESI whether it should still be continued as that, because metformin has had its run. 5 decades of superiority has now finally come that we are questioning it here. And why that? Because like Dr. Karthik said, the CVOT trials were mandated. And in reality, it was done because we wanted to look at the safety. But suddenly what happened, that there were trials that undertook places, and we found that actually they are superior to the cardiovascular outcomes that we were looking at. Because everybody knows that in clinical practice, glycemic targets and symptom relief of the patient is, yes, very important. But the mortality, which is primarily driven by the cardiovascular outcomes, are what we look for when we look up for later on care. And as we move towards precision care and personalized medicine, these things are going to creep in and gain more and more importance. So, okay, so Dr. Karthik said that ADA still recommends this as a first-line treatment. So I would just give you a brief line. 2005, ADA first-line treatment. 2017, ADA said first-line treatment. 2018-19, some doubts started creeping up with more trials that had come. Even till 21, last year, ADA said that it is the first-line treatment, and you look at the risk factors and add on drugs on top of metformin. But in 2022, it had suddenly shifted its poise, and it says that generally, metformin and lifestyle medications are recommended. That is the statement. From being absolute, it has now come to maybe doubtful. You can look at other drugs. You can consider other drugs, especially the ones which have been proven it's beneficial in trials. Further on, why are we looking at ADA? Let's look at Japan. Japan no longer recommends metformin as a first line. It is DPP-4 inhibitors, and it has been for the past 2 years. Endocrine Society, EASD, and European Society of Cardiology both have come up with a joint statement. They said that if CVD is present, SGLT2 or GLP-1 have to be the first line treatment, no longer metformin. And American Association of Cardiology, Clinical Endocrinology have said that if the patient is and can tolerate SGLT2, go ahead. If the patient has a kidney, SGLT2 is a good enough drug you start off with. So now, okay, Dr. Karthik also said that ADA says that if the risk factors are present, then, or if there is established ASCVD of the risk factors are present, then SGLT2 or GLP-1 are the first line treatment. But let me ask you, Dr. Karthik, what is the cutoff when we say that the type 2 diabetes now has the risk factors or not? I mean, we all understand that the line between the primary and the secondary prevention, especially when it comes to type 2 diabetes, is murky at best. So why not start off and consider everyone? And anyway, we all know that type 2 diabetes is a risk factor for future cardiovascular. So because of this murky line, I still believe that all diabetes should be considered as being at a high risk of cardiovascular disease. And also look at the side effects of metformin. I mean, yes, we initiate metformin. I understand it's cheap. I understand it's easily affordable. But let's look at the side effect. 30% end up having severe gastritis or GI disturbances. 5% to 10% end up discontinuing the drug. And then we have on top of it the issues with vitamin B12 and monitoring it annually or giving them supplementations. So these are just side effects. I don't think that these are good enough to dethrone metformin from its oligarchy, but more importantly, let's look at the advantages of other drugs. SGLT2, it's not just weight neutral, it is weight loss, which is one of the pillars that we use to treat type 2 diabetes. It does not lead to any hypoglycemias. It works for everybody as long as they have a kidney. And yes, you may say that, what about the side effects of SGLT2 like urinary tract infections? But over the years, we have fine-tuned our prescription writing to such an extent that when we write metformin, we say it is after breakfast or after dinner. We can also fine-tune our prescription writing by saying SGLT2, start in the middle of the day, take 3 to 4 liters of water per day, maintain urogenital hygiene. And yes, the incidence of these side effects dramatically come down. Now coming on to the actual documented trials that we have. So if we look at the cardiovascular benefit trials from SGLT2, we have the Canvas trial, we have the EMPA-REC trial, we have DECLARE-TIMI trial, and we have DAPA-HF trial. Except for DECLARE-TIMI, most of the trials DECLARE-TIMI or dapagliflozin did not show benefit, but it was non-inferior, while all the other trials showed cardiovascular benefits. GLP-1 trial from Alexa, Leader, Sustain 6, and Pioneer 6, all the trials have shown that they have cardiovascular outcome benefits. And what is the importance and why I'm harping on it again and again? Because the cost of lifelong diabetes treatment is predominantly determined by the complications that the patient face. And if we can intervene and decrease the lifetime risk of these complications and hence the lifetime economic effect of it, then definitely we are moving towards the right path. That is what I believe. And these drugs have shown that the major complications, which leads to not only in-hospital risk, but also if a patient ends up having a heart attack or a stroke and it becomes debilitated, then yes, the economic burden gets multiplied. Further, you talked about the trials of UKPDS, which showed that there was a cardiovascular benefit of metformin. In 2005 trial of a 25,000 Medicare patients analysis that was done in US, it showed no cardiovascular benefit. And yes, and now you may say that the CVOT trials that I've been harping about was done on the background of metformin. But the metformin probably was not the one that was deciding, because that it had an effect. Because usage of metformin could be a proxy that the patient had a better renal function. It probably had a shorter duration of diabetes. It did not require insulin. And we all know in the analysis that was done that SGLT2 per annual usage decreases the risk of cardiovascular events by 5 to 7% annually. And this is being reflected in the updates and the paradigm change that has been occurring in the each annual iteration of the guidelines. Further, the economic analysis have also shown that early usage of these drugs, SGLT2 and GLP-1, leads to economic benefit. And my question is, what is stopping a side effect? We can mitigate cost as soon as the generic drugs come into the market, like DAPA has, the cost has gone down. Mechanistic knowledge, even we are not sure about what is the mechanistic method of metformin. Not glycemically effective, it is definitely. Injectable, no, we have oral drugs. Cancer benefit, really, and aging benefit, if the patient survives to live up to that age, that is when we'll reap the aging benefits. And that's been my time. Thank you.
Thank you, Sedu, for bringing up some of the interesting points. So first, regarding his point on the CVOT trial, regarding of the SGLT2 inhibitors, which is done in the background of metformin. So when you take dapagliflozin and canagliflozin, around 90% were having background metformin, and empagliflozin was the one which had least percentage, with 74%. And there was published a follow-up study on Empara Gautama, where a subgroup analysis was done on this 26% who were not on metformin, and the strength of cardiovascular benefit was not as strong as the one in the other group. That is one point. Then second, the metformin, it has been found that metformin plays a role in potentiating the effect of SGLT2. So they works most probably complementary rather than SGLT2 replacing metformin overall. Then about the KDIGO guidelines, which is the authority for publishing the management of diabetes in a patient with renal disease, they also recommend metformin as the first line and followed and combination of SGLT2 if required. Then regarding what percentage of diabetic patients have a high-risk ASCVD at the time of diagnosis, a study by McMurray et al. Shows that only 4% of diabetes mellitus patients belongs to a high-risk ASCVD criteria based on the ASCVD risk score more than 20%. And about the side effects, you're telling that around 50% may experience the gastric discomfort, but which can easily be circumvented by using a sustained release preparation. And I don't think even 5% will have to discontinue metformin. And the alternative you are suggesting is a GLP-1 receptor analog, which again 25 to 50% will experience severe nausea and abdominal cramps. So I don't think that will be a viable alternative. And of course, there are risks of genital myocardic infections and risk of precipitation of DKA with SGLT2 inhibitors. So overall, I strongly bat for metformin as the first line, and it would require a head-to-head trial with metformin and SGLT2 to dethrone metformin from its current position. Thank you.
Thank you, Dr. Karthik, for dissecting my talk so well. It gives me pleasure that you were listening to me. So coming on to the CVOT trials in the background that you said, and that's why I knew that you would be using that as a point. That's why I mentioned it in my talk. And I would reiterate it that the background effect of metformin does not necessarily mean that it had an effect. It just meant that, yes, the patient had probably better renal functions, and that's why the patient was on metformin, or the patient had a decreased insulin requirement, or patient was of a shorter duration. That's all as we can say. And you did mention that there was a subgroup analysis that was done on the EMPA-REG outcome, but there was a meta-analysis that was also done, which was published in Cardiology in 2019, which categorically mentions that the effect of SGLT2 on the CVO, on the cardiovascular events appears to be metformin independent as well as HbA1c independent. So these two categorically says that SGLT2 does have a direct effect on the heart, and recent studies and mechanistic studies have shown that SGLT2 receptors are present, which by being inhibited by SGLT2 inhibitors can lead to certain mitochondrial changes and the reduction in the oxidases that can lead to decreased remodeling. Further, you said that SGLT2 metformin potentiates the effect of SGLT2. Thank you. Then I would like to say that why don't we start SGLT2 first and then later on add metformin? It's just potentiating the effect of SGLT2. And one thing that you mentioned, that if we have to decrease the side effects of metformin, we can go to the sustained release or the extended release formulation. But I think you are also aware that these are being now questioned because of the risk of increased colon cancers because of it. And as far as the safety of metformin is concerned, until we get the result of the VA impact trial, which is being done on metformin in pre-diabetic patients, I think we should not be so firm on our stand. And one thing I'd like to say is that guidelines drive change. Early adoption means early mitigation means early benefit. Thank you.
Great. Great presentation by both the speakers. Wonderful. I'd just like to place a patient in front of you. This is the patient who is a type A personality. He has irritable bowel syndrome under treatment of a gastroenterologist for past 7 to 8 years. And he develops type 2 diabetes. And as he is a type A personality, he does a lot of over investigation himself. His GI symptoms not great. He got himself with insulin tested. It was coming high. The problem, he was losing a lot of weight. He has lost around 8 kilos of weight in the last 2 months. His HbA1c is 8.4. And he is in your clinic. He's looking for an anti-diabetes agent. And there's a bit of hypochondriac nature. He got his CT done, coronary calcium score came borderline high. He has no symptoms of AMI. His ECG is normal. His ejection fraction is more than 60%, perfectly fine echocardiography. So what would be your agent of choice if you have to start one agent? Just one drug name you give.
Yes, sir. That's what I was doing. No, sir. Irritable bowel syndrome, he is not going to tolerate. He's losing weight. I don't think it will be the first. Sir. So metformin,
I asked this question because both of you highlighted on both the drugs, SGLT2 and metformin. What others?
Sir.
Take only one option, only one drug you have to name it.
GLP-1 would be indicated because of the irritable. I think I would go for DPP-4 inhibitors.
Your take, please.
I would probably also go for the same.
Okay. Another leading issue. Why not a sulfonylurea or a pioglitazone? Why not in this scenario?
So, antibiotics has got a lot of strings attached to it. Again, it has got an increased risk of edema, and patient is so concerned about the side effects of the drugs. They find it, if they go through the literature, then that again would aggravate his concerns. When he reads about the risk of fractures and the risk of bladder cancer, that would make him more apprehensive and doubtful regarding the medication.
Okay, fair enough. What about its beneficial impact on weight gain? He's concerned about weight loss.
There is a lipid state phenomenon, and there's one condition where a weight gain is associated with a better cardiovascular outcome.
Any effect on cardiovascular outcomes?
Yes, sir. The proactive trial has shown that it has improved the cardiovascular outcome as well as the carotid minimal medial thickness.
You spoke about ADA 2022. Where does it?
We need to stop. What did proactive trial say?
What was the primary outcome in proactive trial, and what was the secondary outcome?
Proactive trial was not about the carotid minimal medial thickness.
No,
What was it about?
It was about the cardiovascular safety and reduction in the atherosclerotic cardiovascular risk.
What did it report?
It's a significant reduction compared.
There were two outcomes. There was a primary outcome, which was I'll tell the answer. they are just there's a primary outcome, which is actually a 3-point MACE plus peripheral arterial disease, which was neutral. There was a secondary outcome, which was 3-point MACE, which was significantly benefited with the use of pioglitazone in patients with high CV risk or established ASCV. So just one more question. In Japan, we spoke of Japan, and in the United Kingdom, as per the latest published data, they do all their data publication. What's the leading cause of death in type 2 diabetes? What's the leading cause of death in type 2 diabetes in Japan and in the United Kingdom as per the last published data? It's not cardiovascular disease. It's malignancy, death from malignancy. And you were talking of some anti-tumor effects of metformin. That also comes in.
But Karthik, I have got 2 kidneys, not one. I have got 2 kidneys. Are you sure that I won't develop hyperglycemia with insulin?
Thanks, everybody. We can, sir, you can shoot the questions to everybody rather than the last 2 unfortunate guys who had to stand extra time. Because everybody is waiting for the final results. So in that interim period, we can have some session. Maybe you can have tea and then come.
It's a trial or it's a viga.
If I say that both the pies are wrong, that is statistically less probable than me saying that he is wrong, only 1% wrong. So maybe he has the wrong message. Like what was I'm doing good, but I think I should come for these things more frequently. Young person doesn't have to do long. It's good to interact. For you, it might be like normal part of life. So for me, it is every day, and there might be a pain in the neck also for you sometimes. So, but for me, it's nice, and I like it. And then I do see that I can contribute. Just sort of like even if I can't teach them about adrenal or gonad, at least I can get their hormones and sort of like all that dopamine surge and the adrenergic thing. At least I can calm that down, get them on the right track. Okay.
और बाकी क्वेश्चन
more knowledge and able to see what is going across the different colleges.
So you feel only 3 should go to the last. Okay, so, okay. I mean, everybody is assured of a prize then. Okay, fair enough. Good point, well taken.
So regarding the good and the bad, I would start with the bad first. Considering this is like a festival of academic excellence, so I would have wanted one like 3-day function wherein at least one day we wouldn't have had some homework to do for the next day, and we would have had like a gala dinner. That's the bad thing. The good thing is everything was really good. It was a good academic excellence festival, as I was saying earlier. But one night where we did not have homework for the next day would have been better with probably a.
So you would want the debate topic to be given in the morning?
No, 3 days. 3 days. I said 3 days. One night you make us lose our sleep, fine. But one day, probably just before the last day, like we can have a good dinner, get together there after that.
So a party time before the last day.
Like
Maybe.
the celebration before the storm. Yes. Yeah, exactly. Storm starters.
Good. Yeah.
Personally, I enjoyed the program very much. Just a few comments, just from my side. Others may not disagree. The bad ones, I would say that, from my side, the essay writing part, I think, should be scrapped. And regarding more of spotters, MCQ clinical decision making question should be there. Regarding the MCQ, there are a lot of factual MCQs. The lesser those types of MCQ, the better, I would say. Otherwise, it was a very fun event for me personally, and I got to meet a lot of my friends. I will echo my friend Aviva's suggestions. If it is a 3-day event, maybe more enjoyable. That's all from my side.
3-day, your department will allow you all to enjoy.
Or maybe on one of the evenings, a social cultural event or something like that.
No, we can get 3-day leave sanctioned. The nights will be exempted from that.
Okay.
So you can have a 3-day event. It will be a 3-day, no gala dinner.
Okay, well taken. Yes.
So the good point is probably the grant proposal could have been told a little earlier, sir. Since it's a dream project, probably some extra time we would have not come up with better ideas. And the good thing is that I feel like all faculty were very friendly and not very intimidating. So that's it.
Okay, good. Next.
The bad point, I would agree with Harshita. Suddenly, when the thing of a dream project have to be presented, we were clueless about what is expected from us. So we all have a thesis. So whether it has to be something which is an extension of the thesis, or it has to be something which is a pure dream. So you haven't made any effort regarding that in all these years. So it was difficult. So most of us at least made an attempt to do something which is not related to the thesis itself, instead which is completely different. But in the final comment, it was said that if you're applying for a 30 lakh grant, it is always better that we have some data which is available in that field, and nobody is going to give you upfront 30 lakhs for a subject where you haven't made any effort into. So that was something when as a dream versus what was more practically possible, I found that a better clarity on the topic. And the good point was that it made an overall assessment of each candidate, and it was not only based on what the subject he knows, but also about his or her ability to express things clearly, and also gave a opportunity to meet a faculty, because unfortunately our batch suffered most in terms of the academic activities. Most of these events were online, and we had seen our faculty and also our batch, our colleagues only on the internet. So it was a very good opportunity to see them in person and interact them and know them better than only being competitors. That human being, we were able to meet them in person. So that was a good thing.
Thank you.
Regarding the negative thing, I want to mirror what Debaditya has told. Can bring more objectivity by adding more MCQs or more spotters. I think the number of questions, personally, I feel it was lesser in number, and clinical scenarios, I think that was one part. And regarding the debate, it's my personal opinion only, sir. I wanted the topic only around 1 hour, because giving 1 day prior, I think it is better than on the spot, sir. That's what I believe, sir.
Yeah. It's
And I've heard many of these eminent faculties through these online classes, but it was really, really a dream come true to meet all of them in person. So I did really think it's a very great experience that I will never forget in my lifetime.
So only thing is program format could have been provided a little bit earlier. So we could have prepared much better as like a grant application or something. Otherwise, it was a very good learning experience, a crisp learning in 2 days, dense learning in 2 days. So it was overall a very good event. Thank you.
So we really enjoyed this experience of meeting the faculty as well as our friends also. If the same pattern is repeated over the next year, it will be helpful for the next batch to come. So, and it is gone to YouTube also. So that's a good thing. We know the pattern next time. Thanks.
Okay. By and large, only change, I guess, was the research grant. Rest everything is the same as what has been going as per many number of years. So there is nothing new. Only the research grant was added, and we debated actually how much time to give. That is why we gave almost 72 hours, or I think I put it on Wednesday. Correct. So fair enough. We will give a bit longer time. That's the only change in the format this year. What we have done. Yeah.
The bad thing I felt was, I think maybe case discussion should have been open to more people, because that's what we deal with in real life after this. So rather than limiting it to the last round, maybe case discussion should have been introduced a little earlier. And the good thing was, it feels better to meet in person than to meet online. That's all.
Okay.
Good evening. I am going to discuss a point that is good as well as bad. First, let's discuss a bad thing. We all know that every one of us are champions in some sort of way, in certain fields. So making a uniform diagnosis is good, but as well as bad. My suggestion, it's not a bad, but my suggestion is, let's make it more objectified, like some excels in talking, some excels in reading, some excels in discussing, like that. And that should be done, various aspects of a person's personality would have been more justified. The second thing is, the good thing is it comprehensively evaluates a person. So that makes actually a scholar as per the Aristotle.
Yeah, that is why actually the format is designed in such a way. It is not only the MCQ, not only the subject knowledge. You all are parallel as far as the subject knowledge is concerned. But how best you put it forward in a given time, how best you look it from different angles. Say when you are giving the debate topic, whether to speak yes or no, you don't know, but you should be ready with both the angles ready. So something like that, all those things were looked at. Yes, I agree. Maybe some of things. Yeah.
So my point would be that the MCQs were very, very figure based. That was a quite letdown. At this stage, I was expecting more of a clinical scenario, not value based. At this level, it kind of feels a bit low, because anyway, and I really was hoping that the clinical case scenarios, which actually judge you as a clinician, should have been more at an earlier part, not just towards the end, because that is also part of a personality judgment, but along with that, the clinical skills that we have gathered over the years, instead of the MCQs, those were something that.
Yeah, I agree. I mean, instead of the percentages, 20, 30, 30, 40, those actually, I fully agree to it. I mean, we will definitely put forward a bit better version of MCQs in future. I fully agree.
At least two of you have said about that. We have tried in the past, whenever I've been involved. The challenge was it takes more time per person. So that was an issue. What the current team has done is they have got 3 cases now. Earlier, for many years, it used to be just one long case. And so supposing you get CAH or something, and then you end up making one letter, so then you get 0 out of 100 and everything is sort of tossed. So they are trying. Yeah.
So that was absolutely fine. So I don't have a problem with the timing also. I thought 72 hours were good. I did make a dream project. Like literally I sat down and I made it all. debate topic could be given in the morning also so that we can sleep peacefully at night. But I was really let down by the MCQs. I genuinely. That
No,
was-
absolutely, absolutely correct.
Point
Good.
is well taken. Yeah,
Good.
I admit, I agree with it. And it is not that I've, as an individual, not thought about it. More than 10 years, I've been thinking. Clinical is primary. All of you are supposed to be good at clinical. So that should be checking at the primary level. MCQ might be secondary, how good you are at theory. And tertiary would be how well you can come and debate, how well you can come and speak. So that point is well taken, and maybe the team can rethink. Dr.
Yes,
Belinda, Dr. Hari can
MCQs we will definitely revamp. Definitely, I mean, this will not be the same way as what it would be.
So I
definitely
also agree with them that case presentation, this part should have included everybody. Means that is
Okay.
something which I was also looking forward, that case presentation will be there.
Okay.
But it's all right.
System for time management.
Case presentation, actually the problem comes as it goes and goes. I mean, for them also, like 15 minutes I was standing with everybody.
We would also get a idea of what we are going in final exams also.
See, yeah, it is the only difference being, since it's like a overall assessment, that is not, I mean, you get assessed by cases, that is the only form of assessment all 3 years. But this looks at different aspects. So that is why that is one aspect of it.
Yes, that I agree that all the other rounds are all well said and very good, but this should have been also included, sir, right?
Sure. Yeah, maybe something like we can definitely put. Yeah.
Sure, we can probably.
Sir,
make
comments from faculty, Kala sir.
All points are well taken. I would like to say thank you to all of you for being here. If it is a dream come true for you to meet some of us, and I hope you're telling the truth and not just doing. Hyderabad is famous for a dish called maska pan. So I hope you did. Maska, the Hindi means Karthik. What is the English of maska? I don't know. Buttering. So it is actually a butter bun. It is a butter and sugar bun that you get in Hyderabad. So that is maska bun. So I hope you are not doing maska. But for me also, it is a dream come true to meet you. When I look at all of you, all the boys and girls, I see the future of our country, and I see that it is very bright. It makes me happy. It makes me feel proud. So thank you for being with us.
So I think I would like to congratulate all of you for being here today. And as much as you enjoyed being here, we also enjoyed being here. And we all look forward to your contribution to ESI. And we also want to know what you would be looking forward for ESI to be doing for all of you.
If all 12 of you give us permission, we can make a WhatsApp group. Dr. Belinda, Dr. Thomas, Dr. Deep, Dr. Whereas they will be happy to mentor you. They will also be there. So, what is it that ESI can do for you? That is what we ask. When will you complete your exams, all of you? And if you would want to meet again, maybe the 12 of you, plus 12 people who will qualify for the EV Gandhi. That you the top 24 people of the country. What is it? What skill, upskilling do you want? How can ESI help you in your career? If you can share that, and if you allow them to make a WhatsApp group for all of us, so let's see how things move forward. But do not hesitate. Feel free to write whatever you want to write.
So all your suggestions have been very well taken. We will try to see how we can improve on this as we go on for the next years. And thank you all for.
Yeah. So the same feelings here. I enjoyed the session a lot, and we all learned from each other. Number two, the academic part is well taken during our 3-year stay in our colleges. So extracurricular activities and seeing everybody excelling, what I feel that the way you people present your like cases, discuss your cases, and the flow of your presentation, everything is extraordinary. It's improving, and it's heartening to see these activities, and it encourages us as well. So best wishes to everybody, and I too enjoyed, and interacting with my fellow colleagues is a very good experience. Thank you.
So like every other Tysa, this has been a learning experience for me as well. With every Tysa, we get to interact with the best minds in India. So we get to learn as well. And interacting with students actually help us identify our weaknesses as teachers, help us improve as well. So I think that would be my take home from my aspect. And I would love to see some of you as judges in future Tysa as well. And I hope and I believe that that will happen soon.
So first of all, let me congratulate all 12 of you. I know that today when you go back, only 3 people will be taking trophies home, but it really doesn't matter. All 12 of you have done really well. And as judges sitting here, we've really had a difficult time to tease out. And as Dr. Ankit mentioned, yeah, maybe we should keep it in mind that we should not have just hope because one person will feel left out. But that's all right. It doesn't matter whether you've taken the trophy or not. All 12 of you are the best in endocrinology who have come up to this top level. And irrespective of today's, our marking will depend on today's performance. So maybe you've had a bad day and you've got a little less marks than the other person. So only three people will get the trophy, but that doesn't mean that the rest of you are any worse or better than the others. So take back that positive note with you all. And with regards to the patterns, I think over the years, based on feedback, we have altered our format here and there a bit. And sometimes I feel it goes around in circles because they told us once that they didn't want these long clinical scenarios for MCQs because it takes time to read and analyze. And for buzzer round, today's MCQs were all geared towards buzzer round. So for buzzer round, you wanted that, quick, I want a quick answer so I can press it quickly. So but today we listened the exact opposite from you all. So maybe we should have a mix of all sorts of questions for the MCQs as well. But we maintained MCQs in this round only to add objectivity into it, because all the other rounds were very subjective. It depends on what kind of impression you make on us, and we're all human beings. At the end of the day, we tend to either mark you up or down. So we wanted to introduce at least one round of objectivity, which is why we retained the MCQ round. And otherwise, I think this year we have included the research grant application round, and I think all of you have done well. So overall, I think you all have performed very well, and we have looked at various aspects, not just your subject involvement and your subject knowledge, but how you perform and how you debate with each other, how you interact with each other. You all have been marked on all of those aspects. So congratulations to all of you, and the winners should be proud of themselves, but all 12 of you have performed well as well. Thank you.
I would also echo the same thoughts as Dr. Belinda. So I think many of you would have qualified being the top 3, but unfortunately due to some or other reason might not perform to the best of their abilities. So don't get disheartened, because you 12 are among the best of the lot of the current year. So that is what is more important to us. And judging you has been difficult. I think every judge will agree to that, because it was sometimes very close fought battle. One thing regarding Tysa is one of the premier events of ESI calendar, academic calendar, and here we test different domains, not only related to your academics. So how well you are to write. So I don't think scrapping essay is a good option. It does test your domains, which are quite essential to grow as a clinician. Apart from that, debating, one thing which are also like a duologue, which can be incorporated in future rather from a debate. So that would be an idea. And your feedbacks have been well taken. Regarding MCQs, there were genuinely some difficult questions, but with regards to data, but that is to increase the difficulties of the question. And if we put clinical questions, sometimes what happened in the previous year, people did not have the time to read in those 30 seconds. And it was basically designed for as a buzzer round, as Madam has said. So it was very short questions and a buzzer round. But later on, we modified it to 15 will be given everyone to answer, and 10 were chosen as the buzzers. So anyway, we'll take care of that. We'll not add too much database question, but data is important with regards to your academics also. And all of you performed very, very well. So don't get disheartened. Everyone is a winner here. And I think that will be endorsed by every faculty here. And we thoroughly enjoyed the program as what you have enjoyed.
So first of all, congratulations to all of you. I think all have done well. A bit of here. I think it's a more of a test of maybe performance under pressure. So sitting on this side, it was much easier for me to think answers. Had I been standing there, I would have made more mistakes. So all of you are the most knowledgeable endocrinologists currently who are going to pass out. My best wishes to all of you. And I would just like to add, please take care of your health. This is the prime time of your life from 25 to 40, where your pressures on your life will further increase. You go into practice, teaching, academics. So don't ignore your health. Just a message to all of you. Thank you.
Thank you all. Before before we go and announce the winners, he said, sir, go.
Anyway, I felt like a student after 20 years. It's very nice, and only 3 people should be allowed for the final, or else everybody should get the prize.
Whoever comes for the final should go back with a prize. That should be the motto.
Let me add to what some of the others have said. While some of you were answering, I completed my DM in 99. So when some of you were answering, I actually felt as if I had read the wrong thing. And was I mean, in the wrong subject. So when Dr. Belinda asked a few questions, then I thought, I'm at least, if I'm wrong, then Belinda is also wrong. So that makes 2 of us together. And what Deep said about stress, so especially for some of the boys, relax and your body language reflects the stress that you are in. This is for more than one of the boys. So just feel relaxed when you come. Take control over your thoughts, over your body language, and then automatically you see that your performance will improve. So if you feel that your muscles are tight, just relax them. It will take 2 seconds, and then after that you begin answering.
For all of you, first we should put our hands together for Torrent, who has been supporting us for Tysa. And it's actually with this team who has made all this possible. So big thanks to Torrent from ESI side. Mr. Robin is here, who is from the head office. So all of you would have interacted with him in the due course with other team members, but they are the ones who have been doing Tysa for in many number of years, in many number of specialties. Thank you from Team ESI for the excellent conduct of the program. Okay. Before we go to the winners, the Torrent team is going to give every final participant a prize. I would request in the alphabetical order. So first, Dr. Somashekar Reddy will start giving to the students. Sir, please come here. Dr. Ankit. Keep standing there, sir. Keep standing there. Dr. Aviva. Dr. Devaditya. John T. Johnson. Dr. Karthik.
If you like electro house, if you like dance music, if you like
Dr. Krishna Prabha. Dr. Lavanya. Dr. Setu Gupta. Dr. Swami. We go to the announcement of the final results of Tysa 2022. I would request Dr. Pankaj Agarwal to give the prize for the second runner-up. We will go obviously in the reverse order. So, ladies and gentlemen, the second runner-up is Dr. Devaditya Das. Devaditya, you can keep sitting there. You can just sit there. Thank you, sir. The first runner-up, I would request Dr. Sanjay Kalra, past President ESI, to please give the prize for the first runner-up. Sir, please. The first runner-up of Tysa 2022, Dr. Harshita. Thank you, sir. Now, for the winner of ESI Tysa 2022, to give away the prize, I request Professor Sahai, President ESI, to do the honors. And the winner is Dr. V. Karthik from Trivandrum. Please give a big hand.
Like my dirty sound. I feel you. I feel you.
Congratulations to all the winners and all the participants. The winners, 3 winners, are requested to share their account details later on for the prize money, which will be handed over later. The certificate and trophy, you can carry it. Okay. For all others, all the best. It's not the end. You have AV Gandhi next year for all of you. So you have one more award which you can hope for from the ESI. They can carry the gown home and you can enter the airport like this also. All the best. Thank you all for participating and hope you have a safe and peaceful journey back home. Stay safe and we hope to see you in some of the activities in the ESI in the future. Thank you all for participating.